Okay, so very good afternoon to everyone, and I hope you all had lunch. And it's good to see again all familiar faces. Wonderful to see all of you. Um, thank you for joining our session. This will be the second session, and we have very admirable personalities whom I look up to. Professor Abhi Ghosh, who will be chairing. He is the professor of social anthropology in the Department of Anthropology, Punjab University in Chandigarh. Sir, it's always a pleasure. It's always an honor to have you with us. So Professor Abhi Ghosh will be chairing this session. And we have another very young, dynamic faculty from Ambedkar University. He is Dr. Urfat Anjem Mirror, and he is teaching in the School of Liberal Studies in University, Delhi. And he's also one of the former students of Professor P.C.Joshi. Dr. Mir, always a pleasure and nice to have you. And I'm sure now all the participants are familiar with you because ever since the inauguration, your name has been, spoken about time and again. You have become very popular right from the inauguration ceremony. So, Dr. Mir, so nice to have you. Well, sir, Professor, the chair and co-chair, I was informed by the organizers that Professor MP Sachdev, he is very busy with series of meetings and he will not be able to present the two papers that are lined up in this very session. So you have three speakers for this particular session. So I request the chair and the co-chair to coordinate accordingly. So thank you so much once again. Over to both of you.
Thank you. We'll try to do our best. We have, I think, Dr. Mir, if you will.
Yeah. First of all, I would like to thank the organizers, so the Department of Anthropology, Professor Saswati, Professor Sachdeva, and their team, for giving us this opportunity to join this session.
Yeah. And so I think not only will we have some time for discussions, but also I think we can give a little more time to all the three speakers in case they need it. If they don't need it, we would encourage them to finish in 20 minutes or so.
Yes, I think fine. We can give them 20 minutes, for presentation. So we'll be still having some more time for discussion at the end.
Yeah.
I think that will be fine.
Absolutely. So I think you can carry on with the three speakers that we have here, and we can begin the session, health, disease, and health-seeking behavior. And I hand over to Dr. Mir to carry on the succession of speakers. I think we will have the three speakers and then have a discussion. What do you think?
Okay, thank you. Fine, that's fine. Yeah, thank you.
Yeah. Okay. Let's begin with Professor.
Thank you very much, Professor Abhi Ghosh. I would like to begin the session by requesting Professor Anil K. Sinha to make the presentation. As has already been mentioned by the chair, each speaker will have 20 minutes for the presentation, and then at the end we'll have the question answer and discussion session. Professor Sachdeva, I think, is busy in a meeting, so we begin the session with Professor Anil K. Sinha, Department of
Okay, sir.
Punjab University, Chandigarh. Over to you, Professor Sinha.
Hello. Good afternoon to all. Respected chairperson and co-chairperson. The topic of my presentation is myths and misconceptions about diabetes mellitus in Chandigarh Tri-City. As we know, introduction regarding diabetes mellitus is usually an inheritable and lifestyle-related morbidities of various associated comorbidities and long-term complications. In India, 64.5 million adults, that is 15.3 of the total diabetic patients, are dealing with the disease. The rapid changes in the lifestyle due to fast-growing urbanization in developing countries like India is a major cause of increased risk of diabetes. Chandigarh Tri-City also has diabetes prevalence as reported in recent studies, with 13% of diabetes prevalence, which is higher than 7.3% of prevalence of the disease at the national level. Chandigarh is sometimes also called as diabetes capital of India. Regarding anthropological perspectives of myths, myths often are passed down the generations by word of mouth. It is often difficult to determine the origin of some myths. Myths are defined as stories shared by a group of people which are a part of their cultural identity. People often do not question many existing assumptions in order to not cause disturbance to the regularity and predictability of social life and order. Thus, myths become socially important because they are taken literally to the extent of making people believe about their past and their future. In Indian society, myths are sometimes believed to be self-evident truths, and in cases of extreme behavior, it could be termed as orthodox. Orthodox believe on the implications of the action, and thus they hold a substantial amount control over the believers. Myths are powerful to those who believe in them. They are persuasive because they offer explanation on human nature, society, and their history. Anthropologists in the past have attempted to explain the meaning and the reason for its existence in our society. According to Malinowski, myths serve as charters or justifications for the present-day social arrangement. He emphasized that myth contains some self-evident truth that explains why society is the way it is and why it cannot be changed. He believed that in order to understand myths, we must understand the social context in which they are embedded. However, he has also made it clear that if social arrangements change, the myths change too, in order to justify new arrangements. On the other hand, Levi-Strauss has a different way of looking at myths, as according to him, myths have meaningful structures that are worth studying in their own right, which is part from the uses to which myths are put. For him, myths are a tool to overcome logic contradictions. It would be right to say that the meaning of myth may vary among societies, but myths are meaningful because they reflect the capacity of humans to play with possibilities as they attempt to deal with many contradictions that exist. Still, myths are an integral part of society and are often not questioned because that always depends on the willingness of the members of the society. Now, how do myths gain prevalence? The diagnosis of diabetes in India is mostly done through opportunistic screening and needs to be followed up regularly once diagnosed, even if all the set health parameters return to normal. This mismanagement of the disease may increase the risk of critical low blood sugar, which may lead to serious brain injury or high blood pressure, etc. Hence, the management of the disease with correct knowledge and awareness is utmost priority. Apart from therapeutic interventions, there is a lack of proper counseling and health education, including lifestyle modifications for the diabetics, which leads to myths and misconceptions about the disease. The diabetes and myths. Myths, as already told, stories shared by group of people as a part of their cultural identity, which may have a strong influence in the life and way of living of individuals, including their health-seeking behavior and practices during as well as in the absence of any illness. Myths about disease may be prevalent in a population due to a variety of reasons like poor education, cultural beliefs, and social misconceptions. There are several myths related to T2DM, which are very common in practices, and people have a strong beliefs over them as these have not been correctly evaluated. These myths prevailing in the society are now a major hurdle in its proper treatment and control. Consequences of such myths. Myths often lead people to shuffle between treatments options, and therefore they are not able to effectively cure themselves. Myths and conceptions in any society are passed on to future generations, adding their rapid spread. These beliefs may not only influence the diabetic patients, but their family members and healthy individuals too. Therefore, there is dire need of understanding the myths and misconceptions about diabetic mellitus in order to provide excellent care and health education to patients, their caregivers, as well as to healthy individuals. The present study was an attempt to explore and understand the prevailing myths and misconceptions about type 2 diabetes mellitus in Chandigarh Tri-City. The present study was a cross-sectional study conducted in the Tertiary Care Hospital, that is Postgraduate Institute of Medical Education and Research, Chandigarh, and also in the Chandigarh Tri-City as a part of UGC Major Research Project. Ethical clearance was taken from Institute Ethics Committee, PGIMER Chandigarh, as well as ethical clearance from the Punjab University Institutional Ethics Committee prior to the data collection. Regarding sample size, total 440 respondents, 235 males and 205 females. Diabetic patients 180 attending the treatment at PGIMR Chandigarh with their family attendants 80, and age, sex, ethnicity matched. Non-diabetic healthy individuals 180 participated in this study. The data were collected through the in-depth interview with prior informed consent of respondents by using pre-tested semi-structured interview schedule, seeking information on myths and misconceptions about this disease. The qualitative data collected were subjected to the thematic analysis and then transformed to quantitative data. The present study used mixed method analysis. All quantitative data were analyzed for group-wise percentages and Z-test, etc. by using MS Excel and SPSS 20.0 software. The results and discussion. After evaluating the qualitative data from the in-depth interviews, myths and misconceptions about this disease in the studied population have been listed as follows and were further subjected to analyze quantitatively. Consumption of sugar causes diabetes. Diabetics should never consume sweet. Diabetics can eat anything once the treatment begins. Diabetes is an inherited disease. Diabetes is an infectious disease. Insulin treatment is used in final stage of diabetes. Insulin completely cures diabetes. Insulin treatment is a lifelong treatment process. Insulin treatment can be stopped once blood sugar level is under control. Insulin treatment causes impotence in diabetic patients. Alternative medicine can treat diabetes. Diabetes can affect sexual life. Diabetes affects vision over the long term. Diabetics cannot participate in rigorous physical activities, and artificial sweeteners are safe. These are the graphs, and regarding the analysis of the graph among the diabetic patient, the most prevalent myth is that the diabetic patient should never consume sweets, and the least prevalent myth among the diabetic patient is that diabetes is an infectious disease. Among the non-diabetic individuals, the most prevalent myth is that insulin treatment is a lifelong process, and the least prevalent myth is that insulin treatment causes impotence in diabetic patients. Among the attendants, the most prevalent myth is that diabetic patients cannot participate in rigorous physical activities, and the least prevalent myths are that diabetes is an infectious disease. Insulin treatment causes impotence in diabetic patients. The common myths among diabetic and non-diabetic respondents was that insulin treatment is a lifelong process. Non-diabetic and attendants were of opinion that the insulin treatment is used in the final stage of diabetes and artificial sweeteners are safe. Diabetic and attendants were of opinion that diabetic patients should never consume sweets. These are the tables in which we have shown the comparison of myths between the respondents, diabetics, non-diabetics, and attendants. In this table, the comparison of proportion for myths with Z-test between the different groups have been analyzed. The results are as follows. Non-diabetic respondents had significantly higher prevalence of myth 1, 3, 5, and 7 than diabetic patients and attendants 2. Non-diabetic respondents had significantly higher prevalence of myth 4, myth 6 than diabetic patients. However, attendants have higher prevalence of myth 4 than non-diabetic. Also, attendants have higher prevalence of myth 5 and myth 7 than diabetic patients. The diabetic patients had significantly higher prevalence of myth 8 and myth 15 than their attendants, and lower prevalence than that of non-diabetic respondents. Non-diabetic patients had significantly higher prevalence of myth 9 and 10 than diabetic patients. However, non-diabetics have significantly higher prevalence in myth 9 than the attendants, but low prevalence of myth 10 than same. Diabetic had significantly higher prevalence of myth 11 than the non-diabetics. However, diabetics had significantly less prevalence of same than their attendants. Non-diabetic patients had significantly lower prevalence of myth 12 than the attendants. Non-diabetic respondents and diabetic patients had significantly higher prevalence of myth 13 than the attendants. Non-diabetic patients and attendants had significantly higher prevalence of myth 14 than diabetic patients. However, the attendants have more prevalent myth 14 than non-diabetic 2. This is the gender-wise distribution of prevalent myths in diabetic, non-diabetic, and attendants. Now the myths and facts about diabetes. Myths surrounding diabetes are common and are usually attributable to practices that have not been evaluated rigorously. Understanding the myths and misconceptions about the care of patients with diabetes is important in providing excellent care to the patient with diabetes. To understand the prevailing myths, a few facts related to each myth from the study have been listed as follows, which are collected by the interview of diabetic centers in PGIMER. Myth: eating sugar in excess raises blood sugar level and can result in diabetes. Fact: it is high calorie intake resulting in obesity or excess weight that increases the risk of diabetes. People are not aware about normal blood sugar levels, role of lifestyle changes in control and treatment of diabetes, and that if not treated, diabetes can lead to complications. People with diabetes can eat sweets or chocolates with healthy meal plans and exercise, but people usually misconceive that eating sugar is completely prohibited in diabetes. Myth: once the use of insulin starts, it continues for life. Fact is that insulin is administered to patients before a major surgery or a baby's delivery. It can be stopped thereafter if strict diet regulation and medications pattern is adhered to. Next is there is a cure of diabetes. It can only be treated, not cured. Myth: blood sugar tests and reviews at the hospital should be done once there is fatigue, loss of appetite, and sudden loss of weight, which are symptoms of diabetes. Fact is that as diabetes is a silent killer, it shows no symptoms at the beginning. Myth: diabetics should not continue with medicines once cholesterol level normalize. Doctors are of opinion that one should continue not continuing with cholesterol medicines all through life. Diabetes increases the risk of cardiovascular diseases. Diabetes is not a big deal. In fact, if left unchecked, diabetes can cause serious complications and premature death. Next myth is people with diabetes should follow a special diet and cannot eat sweets. Fact is that people with diabetes benefit from the same healthy food that is good for everyone else. They have to follow a balanced diet, so total per day calorie intake is important. Next is bitter food can help lower blood sugar. Just because some food is not sweet does not mean it will help curb blood sugar. Only bitter foods like neem and karela do not help. Myth: diabetes cannot have fruits. Fiber in fruits helps slowly release fructose into blood. Apple, orange, mosambi, papaya, guava can be taken. Myth: artificial sweeteners are safe. Artificial sweeteners are 600 times sweeter than sugar, precipitating diabetes. Next is diabetics are required to lose weight fast. Fact is, obesity and diabetes are two sides of the same coin. Obese people are advised to lose weight, but sudden weight loss through crash diet is not advisable. Myth: diabetes is caused by eating too much sugar. Fact is that type 2 diabetes results when the body is unable to use insulin properly or sometimes does not produce enough insulin. Myth: taken insulin means you have failed. Fact is that people with type 2 diabetes may initially be able to manage with lifestyle modifications and oral medication, but eventually most people will need to go on insulin. Starting insulin helps better manage the diabetes. Last myth is injecting insulin is painful. Fact is insulin injections should not hurt if good injection techniques are practiced, and the experience will be virtually painless. Now the conclusion. Myths and misconceptions in population prevail due to different reasons. For example, having inadequate knowledge and awareness about the diabetes. Due to rapid increase in the incidence of diabetes in India, preventive strategies are needed to be targeted towards the healthy population. Apart from treatment of diabetes, we need to pay attention to the prevention and health education of people about the diseases. Educational level is protective against myth. Therefore, understanding the myths and misconceptions about diabetes mellitus is important in providing better care and health education to both patients and healthy individuals. We need to educate people and make them aware about this disease and its prevalent and its preventive as well as treatment options. This will play a very important role in control and prevention of diabetes in the country. Myths prevail and stay in societies due to lack of education, cultural beliefs, and dogmas. These beliefs become such deep-rooted that they sound true and get inculcated in successive generations. They may become slightly modified, but stay in a society for a very long time unless challenged by scientific discourse. We need to change the mindset and the behavior of the population to eliminate the myths and educate the people about diabetes. Preventive programs targeted towards general population show greater benefits in this situation rather than targeting only high risk and disease population. These are the references of my study. And then thank you. And chairperson and co-chairperson, may I request you to kindly permit me to leave the meeting because I am regularly from 9 a.m. till now, and I am I have recovered from corona. If you have any discussion, kindly finish it just now. This is my request.
Okay, thank you very much, Professor Sinha, for a very interesting, presentation on diabetes, especially the myths. And I was very impressed by the sort of findings that these empirical findings, especially when you also gave the facts along with the myths. With the permission of the chair, I think if the chair allows, we can open the session for discussion briefly. As Professor Sinha has believed. Professor Ghosh.
Yeah, that was a wonderful talk by Professor Sinha, especially after he chaired the previous session very ably, and now he's been extremely busy since the morning, and I think he will require some rest. But I think the idea that we have myths and misconceptions about every disease needs to be looked at very, very closely and with much detail. And Professor Sinha has done a very competent and very, very good job in doing that in this paper. Are there any comments from anybody in the audience about this paper? Very quickly, two questions I think we can quickly allow.
If you just allow me to just ask, I was curious to know, Professor Sinha, if any intervention based on these findings is in the pipeline or has been, implemented, or you have suggested to the medical practitioners, especially because, as you were able to find the myths, there are facts also about the myths, which I think is very important for bringing about attitudinal change in the community, especially with regard to diabetes mellitus. So I was just curious to know whether any intervention strategy or intervention was made or not, or is being planned.
Sir, regarding PGI-MER, every diabetic patients, they have given a small booklet about this. Please go through it and do not follow the myth. This, and after that, there are some studies of intervention which is published in other journals, but that portion I have not covered in my project. But there are intervention programs by the PGI-MER doctor for every disease, whether it is diabetes, cholera, everything. For postdoctoral fellowship, they have taken this such type of study.
Thank you.
Very good. Anybody else? Anybody else has any queries, any questions?
Sir, there is one question in the chat box. Has it been taken up?
I haven't seen it. Could you read it out, please?
Yeah, I think there's this any observation regarding the perception and myths of genetic predisposition and body shape. Yeah.
No, sir. For it is my study is totally socio-cultural aspect, not from any point of view from genetics, sir.
Okay. Thank you. I hope it answers.
I am a professor in social culture anthropology, and so this is only the social cultural aspect of diabetes, not from medical side.
Okay, thank you very much.
Okay. The thing is, well, if we are discussing, one of my students worked on genetic disorders in PGI along with some doctors, and she was doing some level of genetic counseling and produced a booklet. In the booklet, she talked about many of the misconceptions and ideas that people have about genetic diseases. And in each of the genetic diseases, she tried to cover this area so that people do not follow these, as Professor Sinha would say, these myths and misconceptions. And so these things are available. They are, I think, doing very well in some of the medical departments by distributing this kind of thing through thorough research in the area. And
but chairperson, that are from medical professionals, na? Your students are from medical background.
Yeah, students are from medical background, but then the material that they have produced is for the public who comes there for treatment.
No, that is the view of intervention, sir. That is the view of intervention.
Yeah.
Okay, if there are no more questions, then I think we can move to the next presentation. I would once again like to thank Professor Sinha.
So thank you, sir. May I permit to leave the meeting?
Yes, sir.
Okay, sir.
Thank you, sir.
Okay, welcome, sir.
Okay, now we'll move on to the next presentation of the session. The title of that is Health-Seeking Behavior and the Well-Being of the Slum Dwellers of Delhi in regard to acute respiratory tract infections. Dr. Vijay Sundari Aribam is going to make this presentation. Dr. Vijay Sundari Aribam is a faculty member in Dr. Hari Singh Board University, Saga Department of Anthropology. Over to you, Dr. Vijay Sundari.
Yes, sir. Good afternoon, everyone. Before going ahead with my presentation, I would like to thank the Department of Anthropology, Delhi University, for organizing such a beautiful 2-day seminar and giving me an opportunity to be part of it. At the same time, it's an honor for me as a student of Joshi sir to be part of, anything related with him. So thank you so much. Now I would like to go ahead with my presentation. I'll try to share the screen. I hope it's visible. Yeah. Okay. My presentation is on health-seeking behavior and the well-being of the slum dwellers of Delhi in regards to acute respiratory tract infection. So, going ahead, let's try to understand what is acute respiratory tract infection. It is a major public health issue and also a major cause of morbidity and mortality among the young children. It has two types. One is upper respiratory tract infection and the lower respiratory tract infection. Lower respiratory tract infection is considered to be, more dangerous, life-threatening, and upper respiratory tract infection can be treated. I mean, both are can be treated well ahead of time if we can identify the symptoms. ARIs include a diverse group of diseases ranging from self-limiting illnesses to bronchitis, bronchiolitis, and pneumonia. A variety of social and environmental risk factors are associated with its morbidity and mortality, including poverty, malnutrition, low birth weight, inadequate breastfeeding, complementary foods initiation, overcrowding, poor housing conditions, indoor and outdoor air pollution, and then seasonality and lack of access of preventive and curative measures, services, etc. So about 13 million under 5 children dies every year in the world because of ARI, and 95% of them is contributed by the developing countries. And in India, it's about 26.3 million cases of ARI reported every year, with an incidence rate of about 2,173 cases per lakh population. ARI contributes to 15 to 30% of all under 5 deaths in India. 15 to 30% under 5 deaths. It's it's a good number to health-seeking behavior. What exactly is health-seeking behavior? Health-seeking behavior is defined as an activity undertaken by individuals who perceive themselves to have a health problem or to be ill for the purpose of finding an appropriate remedy. The desired health-seeking behavior is responding to an illness by seeking help from a trained medical practitioner in a recognized healthcare center. Health-seeking behavior in developing countries is characterized by availability of multiple alternative treatment choices. The alternative choices include the application of a home remedy, self-medication with pharmaceuticals brought over the counter on the open market, herbal therapies, or going to a health center or seeking formal health provider. So, however, there is a serious shortage of human resources to provide health services in South Asian region, and it depends on the environment as well. As a result, informal healthcare providers, predominantly unqualified allopathic practitioners, provide majority of the healthcare for poor households in India, Pakistan, Bangladesh. In this kind of, in the poor settings like urban slums, the healthcare services are provided by the unqualified or informal healthcare providers. And then ultimately they are forced to seek them because of their certain obligations. And these providers are popular because of low cost and easily accessible, convenient hours and willingness to make house calls, and their acceptance to acceptance by the community. Now let's go to the slum settings, how it is. So it is estimated that the slum area of Delhi comprises of around 20% of its population. Again, these people living in slums will be suffering from about 50% of all the diseases. 50% of all the diseases happening in Delhi, it's suffered by the people living in the slums. Slums are generally considered to be dirty, unclean, overcrowded, inadequate lighting, lack of ventilation facility, all these things. Now, when we go to the formal definition of slums, it can be defined as a building or group of buildings which are characterized by overcrowding, deterioration, sanitary conditions, or absence of facilities or basic amenities, which because of these conditions or any of them endanger the health, safety, or morals of inhabitants of the community. The slums in India have been described unsystematically developed and generally neglected. And it's overcrowded with coexistence of weak building, insufficient communication, and civic amenities. Now, this present paper tries to explore the health-seeking behavior of the two slums in Delhi, two slum colonies in Delhi, lying in the North Delhi area, and the well-being of the slum dwellers, with special reference to acute respiratory tract infections. The present study was conducted in two slum clusters in Delhi, Timarpur area. It was conducted for around 6 months, and around 1,500 households were covered and 600 samples were taken. Both qualitative and quantitative data were collected through fieldwork. So let's go to the findings. When we come down to the knowledge of ARI, knowledge of the caretakers about ARI, most of the respondents, they knew what is upper respiratory tract infection, simply known as Najlas Dukham, the common cold. All of them know it. They know the symptoms. However, the problem lies when we go down to the lower respiratory tract infection. The symptoms of pneumonia or bronchiolitis, when we ask, they can identify the serious symptoms like chest indrawing. However, they cannot identify the early symptoms like fast breathing or the little changes in their breathing and onset of the fever. They think that it's normal part of the common cold. So they do not seek treatment at that time. That's how the disease, which can be prevented, goes into serious mode, and later on it becomes life-threatening for many people. Now, around 13.4% caretakers said that difficulty in breathing was also another symptom of pneumonia when it is attached with or it is joined with chest indrawing. A few caretakers mentioned fast breathing or rapid breathing as symptom of pneumonia, which was very, very less. Very few people only said this. Otherwise, majority of the people couldn't identify fast breathing or rapid breathing as symptoms. Now, how they attribute the causes to the causes of ARI. What are the causes according to their perceptions? So majority of the people, they thought seasonal change or onset of cold season was the triggering point for getting ARI, acute respiratory tract infections. And then they will often say that, you know, the nursing mother was exposed to rain, or she went out to the cold weather, or they have taken some cold food. She has eaten cold food, and then the mother had fed the child with, after exposing to the cold weather, she breastfed the child. That's how the child got the sickness. This kind of you know, perceptions are there. However, a few people, they talked about physical contact and mingling with ARI can cause sickness to other children too. However, many others believe that ARI was caused by taking cold drinks, cold foods, you know, everything was related with cold, everything was attributed to cold food. Now, how do they sought treatment? Treatment basically is done at home. In the first few days, they will give home remedies and self-prescribed medicines. Self-prescribed medicine in the sense medicines which they think that it was useful in the previous episode. So they will just use the leftover medicine or go get over the counter and then give it to the children. And if it is not cured for some time, then only they start seeking help from formal healthcare provider or informal healthcare provider as such. On the other hand, 16.2% of the caretakers were of the attitude that ARI could be cured by consulting informal prescriber, like Jhola Chhapwala, you know, they also call them Bengali doctors. They will go to them and then ask for this sickness, and then the Bengali doctors, usually they will give treatment. They will give medicine, orange color syrup or yellow color syrup in a bottle which doesn't have any name. Normally they say it's antibiotic. So they are told to use it for 3 days, but in any case, the respondents, they will use it, keep the leftover and then use it in the later on episodes also. This is what happens. A few caretakers were of the opinion that children would be all right without getting any help. Now, home remedies. Most of the home remedies which they use for treating this one, ARI, either the case of a lower respiratory tract infection or upper respiratory tract infection, they will first use ginger and honey tea, bed rest, or cleaning of the nasal discharge, inhaling steam or balm, use camphor, kerosene rubs, or milk, turmeric, jaffle, all these things, all these combinations they will usually use. And after that, when the sickness is not cured or if the symptoms exacerbated, then they will start seeking help from outside. Seeking healthcare provider for ARI. Healthcare providers for ARI, including common cold or pneumonia, was sought by only around 34% of the people there. And majority of the caretakers chose to seek other forms of treatment instead of resorting to healthcare providers, formal healthcare providers. They will normally go to the informal healthcare providers. There are many reasons for that. The main reason for avoiding hospital or formal government hospitals were because the two slums where I did my study, there was no hospital nearby or any primary health center or any dispensaries nearby. Another reason was that they usually say it was very time consuming and they will lose the day's wages if they go and stand in the hospital the entire day in the long queue, and then they won't even get proper treatment for that one. The doctor won't check properly. They will just write some prescriptions, and the medicines are not available in the hospital again. They have to take it outside. So their perception was that instead of just wasting time standing there and spending money, there, they would just go over the counter and get the medicine immediately and give it to the child. So decision making in the family for seeking healthcare for ARI. Decision making was done mostly by the mothers in the sense the caretakers, the main caretaker, immediate caretaker to the children. They will give the they will take decision about the child's sickness, whether to take to a healthcare provider or not. But the father also gets involved in this one. Now, the grandparents also take a part in making the decision at home. And the problem lies when the mother has to seek healthcare help from outside in the sense outside the community or the colony where money is involved. Then the father takes in charge in that kind of situation. Now, okay, here many of the medicines given by the healthcare providers were antibiotic, anti-allergic, antipyretic, unlabeled syrup. Most of them have been, majority of them have got unlabeled medicine from the informal healthcare providers, an antibiotic followed by antibiotic and a combination of unlabeled syrup and anti-allergic. These were given to the children who were sick with ARI, and some of the antibiotics given were mox, amoxicillin, ampicillin, tetracycline, cotrimoxazole, etc. And then anti-allergic cetirizine, chlorpheniramine, malate, and then decongestants and antihistamines. Then antipyretic medicines were aspirin, acetaminophen, paracetamol, brufen, Colpax. These were given. Then among number of days short for treatment given by the healthcare providers, number of days also play a big role. How the treatment system or health seeking behavior collapses, where how much time you spend, how much delay you did in seeking the formal healthcare providers. In the normal cases, what happens is in these slums, they will normally wait for 1 to 4 days or 1 to 2 days. They will just give treatment on their own home remedies or, any kind of over-the-counter medicine and wait. When the symptoms exacerbate, then only they will start seeking for formal help outside formal healthcare providers. Hospitals seem to be the last resort. Hospital is like, when you don't have any other option, when you have to stay in the hospital, then only they seek hospital care. Otherwise, they do not take the children anywhere. They try to solve it on their own in their area, in their house. It is a matter now. Let's come to the discussion and conclusion. It was a matter of concern that onset of difficulty in breathing and noisy breathing were recognized as symptoms of common cold instead of pneumonia. So when you say common cold, they take it lightly, and then they do not seek help immediately. They think that it's a normal process. The weather is changing, and the child will be, all right after a few days. That's how they wait. And in this waiting process, the symptom exacerbates, and many children die because of this waiting time, if not treated on time. It was encouraging, on the other hand, that a large number of the caretakers could recognize chest indrawing, which is a serious symptom of am I still audible?
Yes, you are audible very much.
Yes, absolutely.
Okay. Yeah. It was a serious. Where was I? Yeah. So it was encouraging that chest indrawing at least was recognized by many of the respondents. They call it pasli chalna, and then they don't call it pneumonia. They call it pneumonia or something in their terminology, but still it's almost the same. So they can recognize this serious symptom, even though they cannot recognize the early symptoms. The common perception that ARI was caused by seasonal change or onset of cold weather, very popular among the two slums. Another general perception about the cause of ARI was cold. Exposure to cold was said by almost everyone that if you're exposed to cold, then you will get, pneumonia. If the mother is exposed to cold, or if the child is fed with cold food, then the child has a high chance of getting pneumonia. So this perception came from the humoral theory of body imbalance, where the hot and cold elements have to be in balance. If the equilibrium is broken, then the person will get sick. Majority of the caretakers relied strongly on home remedies and self-medication for ARI, the strategy of attempting to treat childhood ailments at home. As a first line of treatment was explained as cost-saving mechanism to avoid potentially high cost of medical care. Such cost could place further strains on the already limited household economic resources in the case of hospitalization. So to save the cost, they will either resort to home remedies or over-the-counter medicines instead of taking the child to, seek formal health care. Majority of the caretakers were not in favor of seeking healthcare providers or prescribers. Many reasons had been cited for not wanting to seek a healthcare provider. A 35-year-old housewife in Sanjay Basti said, "We only go to hospital if it's something really serious. We have to wait for hours in the hospital, and the cost of going there is much higher than to see our own local doctor here." So they would rather prefer the local doctor who is easily accessible, and then, who, even if they call, then he would come for a home visit. These kind of doctors they prefer instead of going to the hospital or any formal kind of doctor where they pay a lot of money. At the same time, they write a long list of prescriptions, which they spend a lot of money again. This was the general pattern of seeking care. People followed in these two colonies. The common pattern of health-seeking behavior also revealed that caretakers depended heavily on the over-the-counter medicines, which is very alarming. Mothers usually make decisions for seeking care in and around the slum colony and or for giving care at home concerning ARI. In and around the slum colony, that means when the treatment seeking is of low cost, then the mother take in charge. The mother can take decision. But when it comes to going to a formal healthcare provider where you have to spend more money, then the father comes in. And normally what happens is the father works the whole day as a wage laborer or in the construction site or something. He doesn't know the immediate situation of the child, and waiting for the father to come back and make a decision concerning expenses and the money where they have to spend on the doctor. The value of time where the child's life can be saved is lost during that time.
Sorry,
So,
Dr. Vijay, if you could please conclude your presentation,
yes.
So that we are left with some time at the end for discussion. Thank you.
Okay. I'm almost finished. I'm at the end. Mother's autonomy in decision making was limited in seeking care where there would be a need of money. Seeking private healthcare providers or hospital definitely called for the father's consultation. So delayed decision making due to consultation with other family members will postpone the life-saving treatment, and a mild illness can progress to serious ones, leading to the death of the child. And medicines, I'll just say one or 2 points and then I'll wrap up. The unlabeled medicines are mostly antibiotic, which are randomly, given to the children. For, I would say, as I have seen, for any kind of sickness, for diarrhea, loose motion, or fever, or any kind of sickness which come, the same kind of medicine is dispensed, and then they are told to give it for 3 days, which is, according to WHO, you cannot keep antibiotic for only 3 days. You have to go at least 5 to 8 days. Otherwise, the resistant strain of bacteria can develop because of this, creating strains of resistant bacteria, and the clinical efficacy won't be there. So this is one alarming factor which I have seen. And okay, caretakers more often than not see the attitude of the service provider and their comfort level in seeking the healthcare provider rather than their qualification. They do not care. People living in the slum, they do not care how qualified the doctor is, how experienced the doctor is. They are more into their level of comfort where, you know, they are not meant to feel small, but they talk in their own terminology, their own cultural terminology, where they feel comfortable to seek and go to. Informal prescribers serve as the first line of immediate help, as well as easily accessible, inexpensive means of medical care in and around the slum locality, because they have cultural compatibility with the people living there. Therefore, the role of informal prescriber in the slum communities needs to be recognized by the policymaker. Thank you very much. This is all.
Thank you very much, Dr. P.C.Joshi. We have the discussion at the end. Now I will request our next speaker, presenter of the session.
Yeah. May I begin? I think there is this. How many slums did you cover in Delhi?
So I have covered only two areas in the sense the entire Timarpur and Patrachar area of North Delhi. In the beginning, I did in the Simapur area, and that is not part of this paper, but I have done there too. The Sahadra area I have done. And this paper is specifically confined to this area in the Patrachar and Timarpur area where, you know, very close to the Delhi University.
Okay. Now, I would also like you to take a look at cases where this kind of disease is associated with, say, not bacterial, but fungal infections.
Yes, sir.
Medical mycology is a very ignored area of medicine, and we are coming to issues related to that right now with COVID also.
Yes,
with
sir.
black fungus and white fungus and everything else. But I think it's a very old issue and it has been seriously ignored by many. Fungal infections keep happening on the skin, and it is not that the same fungus cannot get into the body and cause infections also. There are other fungi which we catch from plants, which we eat, from crops, which often have some kind of fungal spores and fungal growths sometimes on them. And if even after washing, the spores remain and they can be ingested and it can cause problems. So I think this is a very important area that you have covered. I think you should continue to cover this area at least for the time being. There are, I think, lots of scope for studies being conducted on slums, though much has been done, but there's still a lot of scope. Okay, any other questions?
I think there is one comment, which reads, you were talking about the correlation of number of days of antibiotics to be given with the drug resistance strains of the bacteria. Is insufficiency of a full course dosage a possible cause to mutate to drug resistance? Yeah. Vijay, if you would like to respond to this.
Yes. It's not something which I have said. I'm not a medical doctor who do research on antibiotic, but what I have seen, what I have reviewed with all the papers concerning antibiotic is that if you use the drugs for 2 days or 3 days, and once the symptom is elevated, then you start stopping it. You stop the antibiotic and then start moving on. Then next time it will be ineffective. That is one thing I have seen. And then, you know, there is high chance of resistant strain of bacteria to be developed. That is what I have seen in the papers which I have read concerning ARI, because there is rampant use of antibiotic over the counter.
Okay, thank you. Is
Okay.
there any other comment or question? If there's no other comment or question, I think then we can move on to the last presentation of the session. Thank you, Dr. Vijay Sambri.
Thank you so much.
Now I would like to request Dr. Ainam Devi from Ambedkar University, Delhi. She teaches in the School of Human Ecology. Her presentation is on sanitation practices and behavioral discourses, a case of Kalang, an island village in Loktak Lake, Manipur. Over to you, Dr. Ainam Devi.
Thank you.
Yeah, are you there?
Yes, I'm trying to
Okay.
share the
Yeah, okay,
presentation.
please, thank you. Okay, it is visible. Yeah, go ahead.
Okay. Okay. Thank you, Dr. Mir. Thank you, session chair of today's presentation. Before I give the presentation, I would like to thank to the organizing committee, the Department of Anthropology, Delhi University, for giving me this opportunity to speak on a paper titled Sanitation Practices and Behavioral Discourses. It's also a privilege for me to contribute the same paper in honor of Joshi sir. As Bijaya said, as a student of Professor Joshi, who had guided us in our PhD work, presenting this paper would be like revisiting the field site of my PhD work. And this is, for me, another fortunate moment to connect it with the villagers through the narratives, through the discussions, and also some of the observations I had. I have just selected this topic for the preparation of this particular paper. And it is just a small section of my PhD work, which I've been trying to actually relate it with some of the arguments. So let me begin with my presentation, which is titled as Sanitation Practices and Behavioral Discourses, a case of Karang, an island village in Loktak Lake, Manipur. Historically, whenever we talk about sanitation, it is mainly conceptualized with the concept of waste disposal, and particularly with the human excretal disposal and the patterns of disposal method. And it has been started with a general understanding of scientific outlook from 19th century with what we call it as the sanitary awakening of Europe. Following that, in India also, post-independence, Government of India adopted sanitation programs starting from various programs, but particularly from the program named National Water Supply and Sanitation Program, which was introduced in 1954. Then this program was followed by the Accelerated Rural Water Supply Program, which was introduced in 1972, continued till 73, and then the Central Rural Sanitation Program in 1986. Later, it was followed by the Total Sanitation Campaign 1999, which was restructured as Swachh Bharat Abhiyan or Clean India Mission in October 2014, which is believed to be the largest scheme for achieving successful reduction of open defecation in India. The third point, surrounding environment and settlement patterns translated sanitation into different practices, meanings, behaviors, and identities. Here, I want to connect it with my topic. Otherwise, when we're talking about sanitation practices, there are other factors which are socio-economic, political, that contributes to the understanding of different sanitation practices, behavioral aspects, and meanings associated. But for today's presentation, I'm going to focus more on the role of surrounding environment and how it plays an important role in the translation of sanitation and its understanding. This paper tries to understand the determinants of sanitation and its discourses experienced by the Karang Islanders over a period of time. Now, before going into the details of the study or findings of the particular topic, I would like to share the methodology involved. As I have mentioned that this is my PhD field site, the methodology or the approach which I have used is ethnographic, and also it's proud to be mentioned that I used to spend more than a year in that island village, and exactly 1 year, 4 months, and thus participant observation plays an important role in understanding various life processes and practices, particularly when it comes in terms of sanitation. Other methods like interviews, such as informal, in-depth interviews, case studies, key informant interviews, help me in getting much more accurate data, and also in helping or cross-checking the data which I have collected. Just to give a brief outline of the area of study, Karang Island is a small island constituted of 2 hillocks of around 35.01 acres in the Loktak Lake of Manipur, which is situated 48 kilometers away from the capital city of Manipur, that is Imphal. As many of us must have aware about Loktak Lake of Manipur, which is also considered as the largest freshwater lake in Manipur, it has a very unique feature or characteristic, that is the presence of foams. These foams are nothing but these are the floating grassy masses that are enriched with rich vegetative flora and fauna, which is also acting as the healthier fish breeding site. When I'm talking about fauna, one of the very important characteristic feature of this site is the presence of brow antler there. This is an endangered species which is present only in this particular floating foam area all across the world. The people of Karang Island they remain isolated from the rest of the people in Manipur. They usually receive less schemes and policies from the government. Now, this is an overview of the village. From here, we can get a sense of how the island looked like. It is at the center of the fresh water lake, Loktak Lake, and the circular patches which we could see here in this picture are the floating grassy masses. So these circular floating grassy masses do not stay at these places in a very stable way. They will float as per the direction of the winds, and how they float from one places to other could be recognized or observed from the following photograph. So from here, we could see that no as such thick grassy masses are available in and around these 2 hillocks. So there are certain months or seasonal timings as per the wind direction that you don't observe the availability of these thick grassy masses. And this is the timing where islanders could actually assess lots of resources or even meeting the mainland people in a very convenient way, because there is no blockage for communicating or reaching to the mainland area by using their small canoes. Now, Coming to my topic of study, there are lots of debates when we talk about sanitation on how it is influenced or determined in an area. So lots of studies mention about the scarcity of water, gender aspects, caste aspects. However, in case of this particular island village, the situation of sanitation and its determining factors are found to be different, meaning that there are lots of water, they don't have the scarcity of water, there is no hierarchical structure among the village. Instead, sanitation is considered as a reflection of the particular uh, island ecosystem and socio-economic status of the villagers. So two main factors, that is availability of space and individual level consciousness, is considered as the determining factor for understanding sanitary situation out there. So in order to understand sanitation, I have taken 6 components of sanitation. Those are safe disposal of human excreta, disposal of waste, liquid as well as solid. Third is the collection, storage, and use of drinking water. Fourth is home sanitation and food hygiene. Fifth is personal hygiene. Sixth is environmental hygiene. However, in today's presentation, I would like to focus mainly on the first, that is the safe disposal of human excreta. So the component of understanding safe disposal of human excreta, let us try to look at the construction of latrines, how latrines are constructed, how many latrines were there, few years before, and what is the current status of the availability of latrines out there in the island. So I'll just quickly read out some of the section on the safe disposal of human excreta, which I have written in the paper. In Karang Island, there were no latrines before 1999 except 18 kacha latrines. The 18 households were considered as those who can afford latrines of kacha category economically and specially. All the houses in the village are kacha category with thatch and tin roof. The nature of the settlement pattern was so much closely packed that it is not feasible to build kacha latrines or open pits, as it may lead to disturbances of foul smell circulating the congested settlement areas. However, the scheme provided under the Loktak Development Authority facilitated the low-cost pit latrines, and availability of it was increased starting from 1999 to 2001. There is a typo, so sorry for that. Afterward, most houses could access latrines when some families used them on a sheer basis. During the fieldwork of 2004 and 5 of my PhD work, it was informed that 5 families do not use latrines. Instead, they use the surrounding areas, particularly the space available in the lake. So from the overall understanding of the availability of the latrines, we could actually understand major outcomes which are connected with, in the sense that latrines were preferably used by the people of the island on emergency, else menfolk in every household get up before dawn and reach out to the lake to their respective fish traps or nets to pick up their day's catch and then arrange new traps and nets. Some of them return at home, but the majority stay on the lake and all their natural requirements are performed into the lake, including defecation. The wife or female members or children of the family go to the lake to give the lunch pack and help her husband or parents in the afternoon for a good catch. Thus, almost 70% of the village population spends their time in the lake, and their consumption of the facilities of latrines become very limited. It is therefore observed from their livelihood practices that they spend maximum hours of almost 14 hours in the lake from around 3 a.m. to 5 p.m. in the evening. There were also years of fishing they spent on floating huts and returning to their houses once a month or occasionally. Such a prolonged stay was possible before implementing the scheme of removal of floating huts in 2011 under the Manipur Loktak Lake Protection Act 2006. Regarding children and women, they will just paddle the oars and go out to the nearby distance of around 100 to 200 meters, and then any of the nearby foams will be used as bedding platforms as well as for open defecation. In this process, they will also pluck vegetables available on the foams. It serves many purposes rather than fetching water from a similar distance and using a latrine for defecation. As the foams keep moving following the direction of the winds, they usually try to get a nearby foam for different purposes. Above, they felt that excreta go down deep inside the lake or converted to manure with its own. The rest of the activities such as bedding, collection of vegetables do not get affected by open defecation. Instead of using the foul smell which is created by the modern latrines that is already used by someone or sitting above the same place that is believed to be polluted already, they prefer using foams and canoe, which is much cleaner and smell-free platforms for the latrines. Therefore, open defecation in the lake remains one of the common practices. Now, when we are trying to look at this outcome of open defecation, it is controlled by the governmental schemes. However, because of the occupational situation, because of the socio-economic condition and also lake ecosystem, people are compelled to opt for open defecation practice. When coming to the frequency of cleaning latrines, we do not see much regular cleaning, as we see from the previous discussion that they are more prone to have an open defecation practice. So in that case, frequency of cleaning will happen on a rare basis, such as occasionally, or on the feasibility conditions, like if a family is able to afford economically. So affordability and feasibility, or on festive occasions they would prefer, or when we are talking about cleaning latrines also, it is just simple splashing of water or by not using any of the disinfectants. Now, the second component is disposal of waste, liquid and solid. In order to understand the second component of waste, that is liquid and solid, here I'm considering the waste material which has been generated from the kitchen garbage and also from the homestead areas, or all kinds of the liquid materials, liquid solids, either from mopping, bathroom areas and all. So every household generates the waste material. However, whatever the waste which is being generated from their respective households will directly go on the bank or shore of the lake, or open spaces nearby the homestead area, which is very close to the lake area. And thus, almost all the areas are found to be polluted, and they usually do not check such kinds of the activities, as they consider it as part and parcel of their everyday life. Now, the next component is collection, storage, and use of drinking water. So when coming to the drinking water, they cannot use water nearby the homestead area because of various other daily activities, and also rearing of livestock nearby the water bodies, and also they have to go for some distance away from the nearby areas and then get water, or treated water supply, which is available in the village, but not on a regular basis. So there are 3-4 options for getting drinking water. One is treated water supply, and second is lake water. People go out of almost 500 to 600 meters away from the nearest shore area, and then they'll collect the water or rainwater harvest. And for the storage, they use various kinds of materials in order to store the water, but they don't store water for longer period. So there is not much problem in terms of hygiene or possible infections, which we may expect from the containers. For Other measures of purifications which is available in drinking water are simple use of cloth is practiced by very few people. Generally, non-electric ceramic candle filter or chalk is very common in all the households. However, stone filtering process is also something which is coming up recently. There were only 3 families during my field visit in 2004-5, but recently there were lots of these portable stone filter available in the market, and people have started buying it and using it. And boiling is one of the mechanisms which people prefer to use during the rainy season, as there are lots of these waterborne diseases found to be common during that time. Home sanitation and food hygiene is another component for understanding their sanitation practices. There's no proper ventilation available due to the cluster structural arrangement of the houses. When we were looking at those photographs, their habitational area is towards the foothills of those 2 hillocks. So they're settled in a very area which is found to be clustered, congested, and close to the water bodies. So the way they have constructed their house is also in such a way that it is feasible for people to pass from one house to another house for the communication and for other daily life activities. So usually the direction of the house is found to be facing towards the south. However, in general, the direction of the houses are found to be facing towards the east, so that the entry of the sunlight can be happen easily. But in their case, there are difficulties of entry of sunlight inside their rooms. And when we are trying to understand the home sanitation, there are also use of firewood, mainly for cooking or roasting and smoking of fish. So roasting and smoking of fish is the...
Can you please complete your presentation so that we can at least have 5 minutes for discussion?
Yes, yes, I'll try to finish in 2 minutes. So roasting and smoking of fish is the activity which has happened 24 hours, as this is the main source of their livelihood, and thus it creates a lot of difficult situation in understanding the home sanitation. As I have already mentioned that, there are difficult situations of understanding the ventilation and proper airing system. Personal hygiene, again, is something which is another issue out there. People do not use all kinds of cleaning means and measures which are required for the grooming system, particularly including using toothpaste or toothbrush, or even using sanitary napkins for the cyclical rituals and all. And the last component is the environmental hygiene, where when we look at this environmental hygiene, I am trying to focus on the surrounding environment where no proper disposal of waste is happened, all end up throwing it into the lake. And also there are lots of these poultry animals being reared in every corners, and it has also given a good breeding ground for mosquitoes, flies, and microbes. So from these different components and findings, I would like to discuss the sanitation practice and behaviors in the form of 2 discourses. One is, which I'm calling here as a dominant discourse, and another one is a discourse which is coming up recently, or emerging discourse, which can be considered as the dominant narratives and counter narratives of the dominant narrative. So the first discourse is that people were people were denying about those developmental schemes and measures in terms of sanitary latrines, in terms of the construction of sanitary latrines, by not understanding the determining factors or influencing factors, or how their occupation compels them to take up the practice of open defecation. The emerging discourse is that I have actually forgotten to mention one point, that from 2007 to 2017, for the last 10 years, there were group of Assam Rifles. A company of Assam Rifle was stationed on the hilltop of the island, and because of the coming of these Assam Rifles on the security ground, particularly girls and women, for stop going out to the nearby homes for bedding or for even open defecation. So because of this security reason, they have started developing small enclosures, buying technical measures to draw water to their respective houses. So there is a compulsion coming up because of the policy and policy making arrangement, and which has led to the of new ideas and particularly the improvement in sanitation aspects. Now, while trying to understand the gender aspect of self-sanitation and power dynamics, Khanna and Das in 2005 mentioned that sensitization programs and sanitation policy for the poor will strengthen toilets use and adaptation. So in Karang Island, it is definitely gendered, there is no denial, but this gendered aspect could be observed mainly coming from the side of or from the viewpoint of safety and health issues, not other aspects of water scarcity or caste factor, class factor, or other power relationship which are present in different papers. Discourses of open defecation is being discussed by different scholars, considering it as a belief system, purity and pollution and all. But in Karang, constraints were mainly connected to the nature and duration of occupation. So in short, I would like to say that the sanitation practices and behavioral discourses developed in this particular area could be observed as a product of nature-culture dualism. So this is the reference slide, and so I would like to stop the presentation out here.
Thank you very much,
Thank
Dr.
you.
Hemlata. Thank you very much, Dr. Hemlata. We had very interesting presentations. The first one being by Professor Sinha on myths and misconceptions about diabetes, a study conducted in Chandigarh. From there, we moved on to city slum dwellers and their perceptions about acute respiratory infections, health-seeking behavior, and then Hemlata's presentation on sanitation practices among the Loktak Lake dwellers. Interestingly, the chief guest in the inaugural session was actually referring to, in certain sense, lack of engagement of anthropologists with urban areas and urban problems and disease. But these three presentations and other presentations also reflect that anthropological fraternity in India is very much engaged in studying, the health problems of city dwellers as well as others. So that way, very interesting presentations based on field work, experiences, and narratives, which again reflects the strength of the social anthropologists of using mixed methods approach to understand, the health beliefs and practices. With these words, I would like to once again thank the presenters, and I would like to hand over now this to the chair of the session, Professor Abhi Ghosh. Over to you, Professor Abhi Ghosh.
Yeah, thank you. I hope all of you can hear us. The three aspects of health, disease, and health-seeking behavior were excellently portraying the title of this session, and therefore very well put here by the organizers, and a very strong and very good tribute to Professor P.C.Joshi's work. When it comes to the first one, I think one should understand, just like COVID, every disease, in every case of vaccination, there are certain myths and misconceptions. And it is not only the duty of the doctor to let the patients and the general public know about these, but it is also should be a part of the public awareness part of public health, which should ensure that these things are made aware to the public at large in general, in as wide a way as possible. In the second paper, Dr. Aribam has talked about well-being and health-seeking behavior of the slum dwellers in Delhi, especially relating to acute respiratory tract infections. I think she's picked up a very important part of a health problem that is often being ignored as being just another problem. It is not just another problem, it's a very major problem. And in especially a city like Delhi, where there's a lot of pollution, where there is a lot of infection, then and a lot of people close by where infections can travel fast. It's a very important arena of research. I think uh, she and others should become aware and should continue further researches in these areas. And in the third part, that is Dr. Hemlata Devi's presentation on the sanitation practices and behavioral discourses, you see, uh, I know she has written many papers on on various issues relating to that zone and that area. And it is not possible to explain each and every aspect, each and every problem from that area. But why it is a security risk is because some of those areas adjoin forested areas, and from these forested areas, you have the coming in of insurgents from time to time, and they find it a very convenient point because Manipur is Imphal is very close by, uh, and they can then use that as an area from where to make forays into Imphal. And therefore, this has not just livelihood issues, but its own location as a security, uh, well, sensitive area makes it a very peculiar kind of a problem where I think one should ensure that development practices are enhanced and followed to the letter. And that I think is something that Loktak Lake has been suffering from among many other issues and problems that we've learnt about in the last few decades. Uh, Thanks to all the paper presenters and to Dr. Mir for ably conducting the session. And thank you. I think we'll then hand it over to the moderator, Dr. Avitoli. Uh, please,
Yes,
Dr.
sir.
Avitoli, please take over.
Yes, sir. Thank you so much. A big thank you to Professor Abhi Ghosh and Dr. Urfat Mir for chairing this session, and thank you to all the panelists. It is always a pleasure to have all of you in the seminars that we organize. So thank you. So our second session is over. We are just few minutes. I mean, we are still on time, so I think it's fine. The next session will be moderated by Dr. N. Kennedy Singh. So I will hand over the next session to Dr. Kennedy Singh.
So thank you, Abhi. Thank you very much. So I think, Abhi, we'll wait for just 2 minutes, or shall we start? We'll start. All right. So without wasting much time, this is the third session, which we have a sub theme: physical health and well-being. We have timing from 3:30 to 5:30, and we have a wonderful presentation in our previous session. So like the previous session, we do have the same kind of dignitaries. We have 5 dignitaries for this session, and this session will be chaired by Professor S. Sumati and co-chaired by Dr. Sonia Kausal. So as you know that Madam Professor S. Sumati, she is the Emeritus Professor of Anthropology, Department of Anthropology, University of Madras, and Madam has a lot of publications, and she has 3 books, and she is a member of many of the eminent associations, and the co-chair, Dr. Sonia Kausal. She is the assistant professor, Department of Anthropology, School of Applied Science, Dr. Harsing Gaur Vishwavidyalaya, Sagar. So I hand over the session to Madam. Madam.
Yes, yes, yes.
Thank you, ma'am.
Yes, Kennedy. Okay. Yeah. Yes. Thank you so much once again, Avitoli, and it's the best part of it is we are on time, and we could able to hear all the papers and wonderfully, like though there are some few presenters has not come, but other papers are on time, and it's very interesting, and I've been listening to all the papers right from the morning. And in this session, there are about 5 presenters are here, and so I'm sure the co-chair is also here. I could not able to see her, but Sonia, I hope you're here, and I hope both of us can take the responsibility of listening to all the papers, and then how best we could give them inputs, and see if the time permits, we can also give them scope for question and answers session. I hope, Vitali, all the presenters are there, starting from Shubhu Roy, Murray, Romi, and Shivani, and Venkata.
Yes,
So
sir.
everyone
Yes,
is
ma'am.
present? Yeah. Okay. Then, yeah, thank you so much. Without wasting the time, I'm really keen in listening to all the presenters, as definitely for me it is all new topic, because it's all sounds more of physical health, and I'm sure that all the presenters are some people I've known to them, starting from Shubhu Roy. I request the first presenter to come, and the title is Culture Shapes Body Composition and Blood Pressure Levels, reflection from 3 studies conducted in Eastern India. So, Shubhu Roy.
Well, thank you very much, Professor Sumati.
Yeah,
Hello.
nice meeting you.
Yeah, same to me, and also to the co-chair, moderator, and distinguished participant. At the very outset, I would like to extend my gratitude to the Department of Anthropology, Delhi University, for inviting me in this seminar, make a presentation organized in honor of Professor P.C.Joshi, whom I know for the last 2 decades or more. As an erudite scholar, and of late, we all came to know how dynamic an administrator Professor Joshiji is. My deep regards to him. Before I go into my actual presentation, that how culture shapes body composition and blood pressure level, this is very based on 3 small studies. But before that, I would just like to kick up with the age-old topic of discussion and debate, how physical anthropology or biological anthropology can converge with social cultural anthropology. Now, you see, physical anthropologists and sociocultural anthropologists, they share few basic principles that organize their research. The concept of culture is central to most of the general theoretical orientation of each subfield, and researchers in each subfield, in each of these subfields, share a common concern with documenting the range of variation across societies, within societies through time. What have been notably lacking, one clear example of the integration of biological and social cultural anthropology in the context of a single research design, in which we find both the 2 subfields coming up with their theoretical and methodological strengths, and to answer a fundamental question about human behavior and human biology. Rather, each subfield has viewed the other with some tolerance, but very often with suspicion or even antagonism. However, things started to change with time, and a related development in the expansion of the topical area of medical anthropology, and within that larger topical area, there was a substantive focus on social and cultural determinants of diseases. Say, for example, Norman Scotch in 1962, in collaboration with medical epidemiologists, provided one of the first examples of social and cultural anthropological demonstrating that hypertension varied in relation with socio-cultural variables beyond the conventional explanatory variables like age, sex, and obesity. So in other words, physical and sociocultural anthropologists are converging or on the same set of dependent and independent variables, dependent that is related to health outcomes, and independent on the basis of an eclectic set of demographic, anthropometric, behavioral, and sociocultural variables. The beauty, what I say is very important. Now, the beauty here is that the convergence of research in physical and social cultural anthropology demands an alternative and attention to the methodological issues, that is a continuous interchange across levels of research methodology for theory to the organization of basic concepts to data collection and analysis. Now, with this backdrop note, let me start my presentation. Is my presentation visible? Is my presentation visible?
Not yet.
No,
Not yet.
Not at Chubu.
Okay, just a minute. Is it now visible?
Visible.
Well, you see, this is how culture shapes body composition and blood pressure level, reflection from 3 studies conducted in Eastern India. Now, the study on ethnic variability in adult body composition and blood pressure levels has been a topic of interest in anthropological research since a couple of decades. And we find many researches from India and abroad that have been conducted to identify how ethnicity and body composition and blood pressure levels are related. Even there are researches that we can see that which suggest that how cultural variables like lifestyle variables affect body composition, fat patterning, and obesity, as well as the blood pressure levels. But how the cultural processes generates perception towards lifestyle, body image, and health, and further how they determine body composition and blood pressure levels is a novel arena of research. And this was developed by William Dressler, a US-based anthropologist who, since the 1990s, through his work, developed the concept of cultural consonance and suggests that individuals' reported behavior corresponds to the culturally prototypical pattern that is referred to as cultural consonance. And he cited a number of, with his research, starting from the research he conducted in Brazil, where he showed that consumption of fresh fruits, green vegetables, low-fat chicken, and seafood are preferred as both healthy and prestigious, and individuals belonging to well-off families in Brazil exhibit culturally valued status by consuming this food. Thus, higher cultural consonance stimulates greater intake of healthy and food, and that may prevent the risk of obesity and hypertension. On the other hand, lower cultural consonance in lifestyle was observed among the African American groups living in the United States. In US, the popular culture is likely to prefer thin body shape, thereby emphasizing a low-fat diet. However, African American group living in US prefer to consume fat-based food items more, leading to an increase in the prevalence of hypertension. And here, cultural identification in one hand, assimilates with cultural normative body ideals and lifestyles, and on the other hand, cultural identification contrasts with external cultural cues. Now, cross-cultural studies documented a higher incidence of larger body size and obesity in societies which are stratified, complex, and lead a sedentary lifestyle. It seems that juxtaposition of two facts, like a species-wide metabolic adaptation to conserve energy resources during times of food scarcity, and cultural adaptations giving rise to a greater food security in complex society, and these two likely to increase the incidence of overall adiposity among individuals. Furthermore, the pattern of fat body composition throughout the societies change with the change in the indices of socioeconomic development. For example, at the inception of industrialization, the level of adiposity among human population was found to be high with increase in socioeconomic status because of the inverse association between calorie intake and energy expenditure. However, with the advancement of modernization, the cultural expectation towards body image got changed, and consequently, the concept of thin body shape in women and masculated body shape in men became popular as the ideal body shape, particularly in the Western societies. The affluent class chose to maintain this ideal body shape as they had access to different cuisine and specialized physical training because of plenty of leisure time and adequate financial resources. Thus, it appears that in Western countries, an inverse association between the incidence in obesity and socioeconomic status with the rise in the popularity of the trend of being slim and trim. On the contrary, the thinness is devalued and deemed to remain unattractive in many non-Western countries, including India. For example, in Arab countries, which is socially desirable is a fat body for women, which symbolizes fertility and womanhood. In India, traditionally plump body shape is preferred, and one colloquial statement, "look fat and fresh," quote unquote, implicates like a compliment among the Punjabi women of India for their physical beauty. However, in the contemporary time, we find a trend of being slim and trim slowly creeping in to the mind of the younger people in India. And consequently, we find a shift in lifestyle is observed among them, and that eventually develops an impact on body composition and blood pressure levels. Now, it appears from this discussion or narratives that apart from ethnicity, lifestyle perceived to be good, I'm talking about perceived to be good and practiced by the members of an ethnic group, makes sense in delineating the health of that particular community. So with this note, we in this paper trying to highlight that how culture influences on actual pattern of lifestyle and eventually shapes the composition, body composition and blood pressure levels. There can be ethnic differences embedded in cultural behavior and practices over the health and lifestyle, and it seems that different cultures may encourage or frown upon different foods, and different stages of life may be actively encouraged or discouraged. This is due to the benefits of dangers of consuming these foods at certain times of life: adolescent, aging, old age, childhood, and so on, and in certain conditions. Such kinds of understandings rooted in the belief system are likely to delineate the health condition of the members of an ethnic group. So we did 3 small-scale studies at a span of 5 years, starting from 2014. The first study we conducted in the city of Kolkata, where we compared a group of Marwari Hindu population with a Bengali caste population. The second study was conducted in the metropolitan city of Howrah, which is adjacent to Kolkata, where we compared a group of Hindu caste population along with a migrated group of Santals living there. And the third one is in East Sikkim in 2019, where we compared a Rai population who belongs to the Nepali Hindu caste group and Lepcha and indigenous community. Now, These 3 studies we conducted, and these were the sample size really were very small, but we tried. And what we found in the first study, that what we did in the first study, we actually compared between Marwaris living in Kolkata and the Hindu caste group in the common neighborhood. You see, all if we know that Marwari Hindus originally lived in the Jodhpur region of southwestern Rajasthan, and they started migrating and colonizing different parts of India during the middle of 19th century. And in the Howrah city, what we find that the Bengali Hindu and the Santal peoples reside in adjacent clusters, and these Santals migrated to this locality around half a century ago. And in Sikkim, I talked about that the Rai is one of the major ethnic groups amongst the Nepalese Hindus living in Sikkim, and they have been reportedly settled in Sikkim from the 17th century. And the Lepchas are thought to be the earliest inhabitants of the Sikkim, but have adopted many elements of the culture of Bhutia, and they follow Buddhism, but they still keep faith on their early pantheons of spirits and shamans for management of ailments, and intercede with gods and preside over the rites accompanying birth, marriage, and death. Now, in study 1, what we did, we first interviewed the participants regarding their perception towards health and obesity, blood pressure problems, what type of foods they should eat, and the age range was around 40 years, 30 to 40 years. And interestingly, before we started taking the measurements, and interestingly, few of the participants, they gave the interview about their perception, they gave their thought about their perception, but declined to take part in measurements, blood pressure. When we wanted to measure their blood pressure and body fat, they became afraid. They said, we want to see that, we want to know how much is our fat composition or what is our blood pressure, because otherwise we'll become worried. So they left. They only told us about their own perception. So this is a small, I thought of sharing with you. So we collected, in study 1, the participants, as I said, were initially interviewed, and later we collected socioeconomic lifestyle variables, the type of food they consume, their physical activities. Physical activities were collected for the span of last 1 week period prior to the date of interview, which includes the duration of physical exercise, sitting light work, sitting moderate work, and so on. And we initially did some bivariate statistics compared between these 2 variables, between Hindu and Marwari, and then we applied multiple analysis of covariance by controlling the other lifestyle variables to see whether ethnicity has any relation with body composition and blood pressure level. In study 2, which was conducted in Howrah city, we actually quantified their perception, both in terms of what they think and what they do, by using different scores. We also identified what are the traditional food items these people consume, and we tried to gather information about the frequency of having these foods, their duration of work, and so on. In study 2, so what happened, we find that lifestyle information of the participants include their food consumption, physical activities during the past 1 week, starting from the date of interview, and later on we measured their body composition, blood pressure levels, and so on. And we applied principal component analysis to extract the components of the variables which were considered for estimating the perception, beliefs, and lifestyle. And we found actually there are 4 domains, out of which we found 2 domains which have higher loading after Varimax notation, and we included those and we applied in our multivariate Mankova. And what we found that to understand how ethnicity plays a very important role. In study 3, that is Eastern Sikkim, we reiterated the same protocol that we adopted in study 1. We first initiated, we didn't quantify their perception, but what we did, we recorded their perception, and then we tried to find out what is their actual practice, what they're doing. So whether there is a difference between perception and actual practice, and how it is getting affecting their blood pressure level and body composition. So here also we did the same thing, and later on we used multivariate analysis. Now in each of the studies we used different measures of fat patterning ranging from BMI to fat mass, percent body fat, body mass index, and so on, visceral fat, and all these things. I'm not going into the details. So what happened? What was the result in our first study? In Kolkata study, we observed that the incidence of hypertension and the level of adiposity were greater among the Marwari Hindu group compared to the Bengali Hindu group. Moreover, body composition differed significantly between these two ethnic groups after controlling for their lifestyle and age. Thus, it appears that ethnicity plays a significant role in determining body composition and blood pressure levels. But what we notice significantly is that the perception towards obesity and hypertension and in management strategies between Marwari Hindu and Bengali Hindu groups is different. The participants of the Marwari Hindu groups were found to be contented with their perceived health status and body weight and did not consider bringing dietary restriction to reduce the risk factors associated with obesity and hypertension. Further, the participants did not consider the problem of obesity and hypertension as a cardiovascular risk factors at the age of 40 years of life. The Marwaris also prefer that we should go for physical exercise rather than dietary restriction. And they also have consumed more milk products compared to the Hindu group. What we found consequently, the higher incidence of hypertension along with greater level of obesity among the Marwari Hindu. This finding was consistent with other earlier studies also. Now, contrary to this, most of the participants from the Bengali Hindu group considered,
Please try to, manage your time.
Okay, I'm just managing, just a minute. One study in the same region showed what happened. The perception of the Bengali Hindu groups considered obesity to be associated with increased risk of hypertension, which is disadvantageous for their health. This type of attitude possibly developed concern among them in reducing the burden of obesity and hypertension by limiting the intake of carbohydrate and fat instructions. So these are certain cases I'm just skipping. And what I can say that study one epitomized that both ethnic groups, Bengali and Hindu and Marwari Hindu, had higher cultural consonance. However, such cultural consonance reflects a greater risk in the cardiovascular health of Marwari Hindu rather than Bengali Hindus. In our second study, I'm skipping, where we quantified, we found that in both the groups, the Hindus as well as the Santals in Howrah city, they have a wide difference in perception and actual practices. That means they are similar in the perception and practice level, but when you compare the perception and practice, you find a wide difference. And what we found is interesting that in the second study, that the perception towards the consumption of healthy foods along with moderate level of physical activities could help in reducing the body fat and alleviate the problems of hypertension. But in reality, these participants, irrespective of ethnic groups, hardly undertook any physical exercise or moderate activities. They occasionally consumed healthy foods like green vegetables and fruits. And what happened, in fact, that they have found to have a lower cultural consonance, and the participants who perceived physical activity and consumption of healthy food as healthy lifestyle showed an inverse association with the measures of body fat and blood pressure levels. On the other hand, the actual pattern of lifestyle of study participants, which was quite dissimilar with their perception, also showed strong influence on body composition. So we epitomized from this particular study that Bengali Hindu and Santals both signified the importance of moderate physical activity and consumption of nutritious food in order to achieve healthy life. But the members of both the groups often failed practicing such healthy lifestyles regularly. And this gap between the belief and practices reflects lower cultural consonance and promotes a greater cardiovascular risk factor. And the third study, where we did on the lepcha and the rice, where we found that what we found in that study, that a noticeable difference in the perception towards obesity and hypertension in the management, and also in the management between Rai and lepcha participants. The lepchas were least bothered of being hypertensive, and they never considered this as a cardiovascular risk. Rather, they considered hypertension as an adaptive development towards cold climatic condition at this high altitude. They preferred to consume salted tea with butter on a regular basis, since they believed that the adaptive strategy could increase the energy for performing strenuous physical activities at the high altitude, and perceived their regular involvement in tireless activities moving uphill and downhill, and that helped them to combat with that particular strenuous exercise. Otherwise, in the Rai community, what we find that most of the participants perceived obesity to be largely associated with increased risk of hypertension, and they believe that obesity helps reducing physical energy and promotes health hazard. This type of attitude possibly developed concern about them to lessen the burden of obesity and hypertension by following or adopting some healthy lifestyle. So we epitomized from this particular study that members of both the Rai and Lepcha ethnic group had higher cultural consonance. However, such cultural consonance promotes a greater cardiovascular risk in both the groups, probably because of their abode in high altitude. So we concluded from this diversity that ethnic diversity remains embedded in cultural behaviors and practices, and the kind of practices rooted in the belief system of an ethnic group is likely to delineate the health condition of the group of members. Members of ethnic group who closely approximate the prototype of the beliefs and behavior encoded in their cultural model are likely to reflect higher cultural consensus and thereby a reduced health risk. On the contrary, inconsistency between perception and behaviors reflects lower consequence and increased risk. Thus, cultural consonance we found intercedes the association between lifestyle and health. Thank you. Sorry for taking a little bit extended time.
Thank you so much, sir, for this enlightening presentation. Yes, ma'am.
Yes, who is talking? Yes, Sonia, you can proceed. You can proceed.
Sir has very rightly in the beginning said that how to converge the biological anthropology and socio-cultural anthropology. And I think medical anthropology is one branch where if we give biological anthropology at one end and the socio-cultural anthropology at one end, then in the middle we can take the methods and techniques from both the branches and conduct the studies and research. So it was a very enlightening paper. Next presentation will be given by Professor B. Murray, and he will be speaking on challenges and prospects of beta thalassemia screening, global and Indian scenario. So please.
Moderator, madam, there is one WhatsApp message from Professor Arup Bandyopadhyay that he wants a clarification. What do you mean by body composition towards? I agree with what he has said. I just would like to respond. One is whatever he has suggested is correct, that it should be body fat patterning rather than body composition, because body composition includes many things. In some case, somewhere I mentioned about body composition and somewhere fat patterning. It will be, ideally, it would be fat patterning. I really agree to what he has suggested. Thank you so much.
Okay, sir. So now I invite Professor B. Murray for his talk.
Thank you, Sonia. Indeed, it is very challenging to speak after Professor Subure has spoken. I was just listening. I was, in fact, mesmerized by the presentation. And after that, you feel small after listening to him. But let me try my best to speak on the topic, challenges and prospects of beta thalassemia screening, the global and Indian scenario. And there is also another speaker coming after me on a similar theme. And I hope that this two presentation will be a continuous one so that we can have a longer time to discuss on the issues of thalassemia. Now, the paper that I'm going to present is not a research paper, but it is in fact a review paper on thalassemia screening, which was conceived during one of our research works on molecular screening of beta thalassemia in Gujarat. And my student, Kanendra, was much more involved in bringing out this review. Let me just share the screen. Do you see the screen? Do you see my slide?
Yes, sir. Yes, sir, we can see.
Yeah, Professor Murray, it's visible.
Okay, yeah. So here, I'm not going to deal with the molecular characteristics of the disease, but rather I shall try to highlight the problems and the possibilities of curbing the disease through community-based screening. So if you look at this map, the thalassemia disease is highly prevalent in the Mediterranean basin, and then parts of Africa, and then through the Middle East, it comes down to the Indian subcontinent and to Southeast Asia, and further extending down to the Pacific Islands. So the entire pale orange color here that you see is known as thalassemia belt. Now, the problem of thalassemia as a genetic blood disorder affecting the hemoglobin has caused a lot of health burden in India and also on a global scale. Now, if you look at the global burden of disease, then we see that thalassemia ranked 68th position in causing burden of health in terms of the disability adjusted life years. It affects the disability adjusted life years, DALYs, which means DALYs is the total number of years lived with disability and the years of life lost due to premature mortality owing to the disease. And apart from this also, thalassemia is seen as an important indicator that contributes to under 5 mortality. Because in the age group of 1 to 4 years, in the global burden of disease, thalassemia ranked 24th in the global burden of disease in the age group of 1 to 4 years. So it is an indicator for under 5 mortality also. So with this introduction, let us go to the next slide. I just want to highlight the sources from where we got the information. Now, in our literature review, we first made comprehensive scoping searches for all the published literature in the last 5 decades, that is from 1970 to 2020, using the electronic databases such as the PubMed, ScienceDirect, and Google Scholar, among others. And then we also searched the organizational websites, the organizational sources dealing with the studies that are exclusively based on screening programs for beta thalassemia carriers. And we got information from the World Health Organization, from Thalassemia International Federation, from Indian Council of Medical Research, Ministry of Health and Family Welfare, particularly the National Health Portal. And then we got information also from the Indian Red Cross Society and others. But we have excluded other things apart from our focus of literature review, which is to look into the programs and strategies for thalassemia screening. We have excluded the others. Now, let's go to the next slide. Now this, if you look at the global scenario, and the manner in which thalassemia screening is carried out are structured in, the manner in which carrier screening are structured in different countries and among different population groups. It varies greatly. For example, there are variations in whether the screening should be mandatory or voluntary. And there are also variations whether counseling must be provided along with screening, or whether screening should be conducted at pre-pregnancy or anti-pregnancy stage, and so on. The manners varies from country to country. And therefore, we can say that there is no consensus of the most suitable way of screening, primarily because of the differences in culture, social belief systems, and the form of governance. But the question whether the screening should be mandatory or voluntary is faced by all the countries across the thalassemia belt. And so we can assuredly say that there are two types of thalassemia screening. One is mandatory and the other one is voluntary. Now, the WHO do not encourage the mandatory screening, as it is clear from its 1998 report, for reasons that it is infringing into the individual rights and the reproductive rights of an individual. But we can see, nevertheless, some countries including Iran, Saudi Arabia, Palestinian territories, and Cyprus have already laws in place, making premarital screening for hemoglobinopathies mandatory for all the couples before they are given approval for marriage. Now, this is reported in some studies, including the studies made by Darazi and Gowan, as you see it here. So we can go to the next slide. I just want to explain some models that are taken up globally, the models for thalassemia screening. So let us look at the Cyprus model. In the 1980s, Cyprus came up with quasi-mandated premarital beta thalassemia screening. And if you look at the history, 50 years ago, Cyprus was one of the countries with highest beta thalassemia incidence in the world, with an estimated rate of 1 in 7. So out of 7, 1 is infected. And particularly among the Greek Cypriots. Now, these Greek Cypriots, they are the ethnic Greek population living in Cyprus. So the premarital screening was mandated by the Cypriot Orthodox Church. And the couples wanting to get married were first required to be screened and counseled by the officials in the thalassemia center. And thereafter, they are giving certificates. And only after this, the priest will declare them as married. But the premarital screening was kept confidential. And the carrier couples were also given the right to get married if they wish. So if you look at this, this is a quasi-mandatory screening, and this strategy was found to be very effective. And in a span of 20 to 25 years after implementation, in the year 2007, the country was able to achieve zero thalassemia status. Now, if you look at the Montreal model, the Montreal model of screening beta thalassemia is also employed by many countries. In Montreal, genetic screening program was conducted in high schools in the 1970s, which went on for 2 decades. So before the screening, information about the diseases was provided to the high school students. And the students were given time. They were given some time to provide their consent for the testing. So this is also found to be very effective. And many students have come forward to participate in this program. Then there are also voluntary carrier screening programs. There was one voluntary carrier screening in Sardinia, that is in Italy, in the 1970s. And this program was also found to be very successful, with a reduction of the incidence of beta thalassemia from 1:250 to 1:4,000. 1:250 in the year 1975, which has gone down to 1:4,000 in the year 1995. So in a span of 25 years, there has been a great reduction, even in the voluntary screening also. Then there are also screening in South Asian at-risk countries. In 2005, Witherell reported that several South Asian at-risk countries, such as Thailand, Taiwan, Singapore, Maldives, and Sri Lanka, have their own national screening programs in place. Now, now let us look at the beta thalassemia screening programs in India. Now, if we look at the reported frequency, it varies from 1 to 17% in different population groups of India. That is the frequency of beta thalassemia. and the overall prevalence frequency is about 2 to 4%. Now, this amounts to 35 to 45 million carriers in India. So community-wise beta thalassemia carrier frequencies have been reported by different scholars in different regions of India. For example, certain communities like the Sindhis, Bhanushalis, and Punjabis from Western and Northern India have higher prevalence of 5 to 15%. And this was reported by Mehta and his associates as early as 1972. And there are also initiatives by ICMR. Under the National Multicentric Task Force, there was one study that came out in 2000 to 2005, and there was a screening project which was based on 56,814 college students and pregnant women. Pregnant women were screened, and this was carried out in 6 states, in Maharashtra, Gujarat, Punjab, Karnataka, West Bengal, and Assam. And the pooled data showed that showed a carrier rate of 2.78. So there has been also mega screening projects that has been done in India. There are many other initiatives like the initiatives for beta thalassemia screening, which have been carried out by the Red Cross Society, by also different programs like Prime Minister Jai Vigyan, Thalassemia Control, and also by many NGOs and independent researchers. Now, what I'm trying to say is that there are still existing problems in India. Premarital screening has been available for decades in India now, but with very little success. There are hindrances for successful screening. Now, if you look at it, one, we may find the cultural practices. Cultural practices often discourages the emphasis on premarital screening. For example, the stigma that is associated with thalassemia is a restraining factor for revealing thalassemic status. Yes, please.
So we are left with only with 5 minutes.
5 minutes. I'll finish in 2 minutes. Yeah. And then the risk of not finding a spouse affects women disproportionately, and parents are not inclined to test their daughters. Then we can look at endogamy. Endogamy is still a resilient caste-based practice in India, and the cross-culture marriage, which would have reduced the severity of the disease, is prevented because of endogamy. So what is the need? It is very important that the prevalence of this disease in the country is controlled. And so screening programs for beta thalassemia should be aimed to sensitize the community to the problem. What is the problem? It should be aimed to sensitize the community to the problem. If they know the problem, then they can go beyond the cultural barriers. Now, further, many scholars have reported that cascade screening, that is screening the biological relatives of the affected, is one of the most cost-effective approaches to identify beta thalassemia carrier. And so it should be also encouraged. Now I'll just close. I have a few observations and suggestions. It is observed that both in India and globally, the lack of proactive stance of the governments remain a challenge. Now, it remains a challenge still, even now, but it is strongly felt that a combination of the Cyprus model, the Montreal model, and the Sardinia model, if you combine these three in the context of Indian culture, then this would effectively curb the incidence of beta thalassemia in India. Now, in India, there has been a nationwide effort to promote awareness with intensification of beta thalassemia carrier screening, jointly initiated by the government and non-governmental organizations since the 1970s. However, the need for genetic counseling of carriers has not been effectively implemented except in a few private institutions. Now, this has led to the growing burden of the disease, leaving behind a vast majority of carriers in ignorance. So finally, large-scale community-based premarital carrier screening programs coupled with adequate awareness and counseling mechanism is needed to make India a thalassemia-free nation. So this is our observation. Thank you so much.
Thank you so much, sir, for this very informative presentation on thalassemia, especially in Indian context. Thank you so much. Now, I would like to request Professor Romi Dev to present his presentation. He will be speaking on status of beta thalassemia in India, challenges and road map ahead. Sir, virtual platform is yours, please.
Good afternoon.
Sorry,
Good afternoon. And it's almost a repetition, I think, like Dr. Moore's presentation and mine. But anyway, like since it's prepared, like we'll be presenting, and it's not almost a repetition, you can say. Had I known it earlier, like I got to know a little late. Otherwise, I would have given something else. So anyway, so first and foremost, good afternoon, everyone, and thank you, Delhi Department of Anthropology, University of Delhi, for inviting me in this prestigious national seminar on anthropology of health and well-being, which is being organized in honor of our respected P.C.Joshi sir. So it's always a pleasure for me to be in the department because it's your alma mater, and I always enjoy being there. So just to mention, like I have known Joshi sir for many years now, and sir has been always very kind and supportive towards us, towards the Department of Anthropology, which is a very upcoming new budding institute. So we are very fortunate to have such support. So I would like to mention that here, like Joshi sir is a person whom I feel is with a beautiful heart and a strong spirit. So it is always a blessing to be associated with such people, and we are very honored to be associated with sir. My sincere thanks and gratitude to Professor Sachdeva sir and all the organizing members for giving me an opportunity to deliver a talk in this auspicious occasion. So before I also made a presentation, and I would like to share that. But once again, I would like to say that it's almost a repetition of what Professor Moore has done, but then it will only give a little bit of more clarity when you see both the presentations. It might give you a better understanding of thalassemia, which needs to be controlled and which is the need of the hour now. So with this, I share my PPT. Are you able to see that?
No, ma'am, not yet.
So just try. Are you able to see now?
Yes, ma'am, it's visible.
It's visible. So this is the same thing which you have heard so far from Professor Moore, but then once again, so my topic is on current status of beta thalassemia in India and a roadmap ahead. So thalassemia, as we all know, it's like, and just now Professor Moore has spoken that it's thalassemia hemoglobinopathies, and which arise as a result, it's an inherited genetic condition and which originate from a lack of malformation of the adult hemoglobin protein. And it's basically a hereditary hemoglobin disorder. Particularly this beta thalassemia and sickle cell diseases are the most common single cell disorders globally and are also one of the important cause of genetic mortality and morbidity in the community and society as a whole. So they represent one of the most common monogenic disorder in India, rendering to a very heavy economic burden on the families and nation. So when a child is born with thalassemia, and depending on the level of its impact, Like it is a devastating matter. Like it brings a lot of psychological pressure as well as financial implications when a child is born with thalassemia, if it is of a major type. So they represent, so in the severe form, they are associated with chronic life impairing and life threatening diseases that can lead to the disability as well as mortality, which I have already said. So considering beta thalassemia, unfortunately, like we know, like many children across the globe continue to be born and suffer from it, mainly due to the lack of awareness, which Moraes sir has given a good understanding, like how the different models have worked in different countries and how that can be controlled. So considering that beta thalassemia, unfortunately, many children in our country and across the globe are still born and they suffer from it, mainly due to the lack of awareness, lack of comprehensive programs and strategies to prevent them. So like if the thalassemia screening, which is not accepted by the community, and as already told by Moraes sir, that it is something which is not yet approved by WHO. So it is involving an alteration in the globin chain of the hemoglobin molecule, that is alpha and beta chain, that makes up the hemoglobin molecule, and it's classified as either alpha or beta thalassemia, depending on whether the alpha or beta hemoglobin gene harbors a mutation. So here that makes us say that the disease is classified as either beta or alpha or beta thalassemia, depending on where the gene is getting affected. So basically, if you go for understanding the genetic part, I'm giving you a brief understanding. I don't know, I can't go into much details. That 4 genes, 2 from each parents, are needed to make enough alpha and beta protein chain of the hemoglobin molecule. And the severity of this thalassemia is determined by how many of these genes are affected. Higher the number, more severe are the symptoms. So beta thalassemia caused by the mutation in the human beta globin gene is more diverse as compared to alpha thalassemia. So if the beta thalassemia is more prevalent, as I told you in the beginning of my presentation, like it is much more than beta thalassemia, and sickle cell anemia is one of the more prevalent issue and problems which the community faces. So beta thalassemia caused by mutation of human beta globin gene is more diverse, which is caused by the reduction of alpha beta globin and is characterized by a quantitative reduction of the beta globin. So next point comes to beta thalassemia caused by the mutation. So different type of beta thalassemia includes beta thalassemia minor, the point 3 which we have said here, like it is minor carrier trait, then intermediate and major. So in my next slide, I would just like to give you a clarification of what beta thalassemia minor means and what is beta thalassemia intermediate and beta thalassemia major. So in minor, the individuals with beta thalassemia have a mutation in one HBB gene and are carriers for the disorder. And they are like in their external appearance, they are absolutely normal. Few have mild symptoms, and the mild symptoms are like mild anemia. Whereas in intermediate, individuals with beta thalassemia have 2 mutated copies of human beta globin, and resulting in significantly reduced level of beta chain. And they may or may not see in the severe cases, the blood transfusion is required. Whereas in the intermediate phase, there may be a requirement for the blood transfusion or may not be. But anyway, there are certain symptoms which are observed in the intermediate, like mild to severe anemia, as well as like what we mentioned in the slide, like sluggish growth and bone defects and bone defects. And the condition, like in major, it's a regular blood transfusion for the management of severe anemia, which slows down the development in the infant and young children. So this is very important point which we need to understand, and these are the major bifurcation of thalassemia, beta thalassemia. Then according to WHO report, and where Dr. Moore has already explained you, like it in 2008 report, 4,000 infants were born with thalassemia, of whom 2,500 are transfusion dependent. So though it's quite an old data, but then it was that like this, and I don't think it's much change. There's much change in the present scenario, and because of some time constraint, I could not go to the literature beyond this. So worldwide, beta thalassemia has been observed to be highest frequency in Mediterranean region. And here I would again like to mention Professor Moore's presentation, where he showed me a good representation of with the first slide of his. So the Middle East country, then the Southeast Asia, and lowest in Northern Europe, where so you saw that orange color belt in the map which was showing, and it is like the thalassemia belt. So the prevalence of the carrier rates of beta thalassemia is relatively high in Southeast Asia, with the report prevalence ranging from 1.25 to 1.66 in India. So like if you, and it's very high in the Middle East country, and one of the reason for this increase is the cultural preference for consanguineous mating. So another very, very important factor where consanguineous mating is giving, is increasing the number of thalassemia in the beta thalassemia in the community. Now, there are various screening programs which have been effectively developed in multiple countries and have been tailored to the local needs and the customs. So as given by Professor Moore, I'm going back to his presentation because it's similar and I did not repeat, and I don't have that. So like it's the Cyprus model, Montreal model, where they have, it is when we speak of the local needs and the customs, we go to that, what is the requirement of the community, how they will understand and how they will accept it, because it is not only the research and screening which we need to do, it is also the acceptance of the population and community, you know, because many a times if you speak to young girls and you ask them that would you like to understand, if you teach in the class and you ask them that would you like to know your thalassemia status, and most of them they say no, because after understanding the subject, so there are a lot of stigmas associated. So in order to change the, first and foremost, we need to create the awareness and change the mindset. If you can speak, I'm speaking basically a very narrow understanding of the population. I've just spoken to the class, but then I think that will be applicable to others as well in our country, especially where there are so many stigmas and myth associated with everything, and especially even with dealing with health issues. So Cyprus success story is known to you, which has been very nicely explained in my by my previous presenter. Then similarly, the Greek National Prevention Program for Thalassemia and other hemoglobinopathies, which began in the year 74 and involved education and prenatal diagnosis, has resulted in substantial reduction, which is also very well explained in the previous presentation. So in the number of affected newborns from 150 to 200 cases per year prior to the screening program to less than 5 cases per year by 2010. That is an amazing progress. So this has come with the help of screening. So this type of programs are very, very important, and which we need to remember as a researcher and as a citizen. So thalassemia and structural hemoglobin variant are commonly in India, but not only, but to a small percentage of patients are properly treated and prolonged cares are given to their family. So if you see every year, like every year there are 10,000 to 12,000 children who are born with beta thalassemia and beta thalassemia, and it is the common, and as I already told you, it is the common single gene disorder in India, accounting for the highest incidence of offspring mortality. So it's a it's something even in 2014, it has been reported in this manner. So it is, I think it's the need of the hour to how to prevent this mortality and how to save the lives of these offsprings, and how can we do that? So by understanding the background, I think we can, or we as researchers, we as individuals can think and proceed in that manner where we can help our nation to reduce this dreadful disease. So the overall prevalence of beta thalassemia trait was 2.78% and varied from 1.48 to 3.36% in different states, while the prevalence of beta thalassemia trait in 59 ethnic groups varied from 0 to 9.3%. And despite various studies, very limited information is available on the prevalence of beta thalassemia and other hemoglobin problems among various ethnic communities and groups across India. So here there's this graphic, this representation in the map where it has been taken, it has been reported by the National Health Mission guidelines of hemoglobinopathies in India in 2016, where they have represented, and those with which is marked in blue, they are the areas where beta thalassemia is very prevalent. So previous research, like here you can see like some population in Western and Northern India, such as Sindhis, then Kachis, then Bhanushalis, Kachi Bhanushalis, and Punjabis have a very high prevalence of beta thalassemia. Then the highest prevalence of beta thalassemia phenotype, which is expressed, are observed in the gens from Bangalore, that's 9.6%, followed by Buddhist and from Mumbai, and Sikhs and from Ludhiana. So according to Patel et al., like Bhanushalis and Bhaktas and Lohanas from Gujarat have a high prevalence of beta thalassemia trait. So which and that is very well you can see in the map. So and if you go to the yellow marked places are for sickle cell anemia, and that is for hemoglobin E. So the green portion, which is very rare and which is only found mostly in the northeast part of our country. Now reported, these are the ranges which I have reported in the slides. So for this, you know, like what the previous research have they are done, like how the variation. Yes.
5 minutes left.
Okay, I'll just rush up. Don't worry. This I won't repeat because it's already told by Professor More. This is also already discussed. And then I just come to the molecular characterization, where I'll just be very brief. Like the beta globin chain of hemoglobin molecule is encoded in by hemoglobin gene, which spans from 1.6 kb on the short arm of the chromosome 1. And various populations have shown that more than 2,000 beta globin gene mutation, with a subset of 40 mutations responsible for majority of the beta thalassemia cases globally. So beta thalassemia is inherited in an autosomal recessive pattern, and recessive genetic order occurs when an individual inherits this abnormal gene from each of their parents. And types of mutation which causes beta thalassemia are like splicing, regulatory, deletion, insertion. So different cases of beta thalassemia gene mutation underlie beta thalassemia. These include these parameters. And out of over 200 casual beta thalassemia gene mutation, in beta globin, 11 have shown to be common in India, which are mainly community specific, and this can be instrumental in identification, diagnosis, and curtailing the propagation of this disease. So the mutations are occurring in this particular position, like which is there in your slide. And out of 6 mutation, intron 1, position 5, G to C is the most common in Indian mutation, and is found in most states of India, whereas among the migrants from Pakistan, 619 by base pair deletion is found to be most frequent. Now the distribution of intron 1 in India is like, the distribution is shown, it is in West India, it is 18%, Haryana 16%, Punjab 7%, Uttar Pradesh is again 16%, and South India is very, very again high. South Indian population have 23%. And what's the reason? When studies show that it must be consanguineous marriages could be one of the reason, and 20% in East India. So challenges and way forward. And again, very briefly, I'll go for this. This is an enormous burden in India, emphasizing on the creating strategy and reduce. And it is very important, very necessary now to reduce the burden of the disease among the vast population. And from the past decades, management of the disease has been possible to an extent with regular blood transfusion, then ion chelation therapy, but then the complications are still associated with the disease, and the disease is in increasing manner. But though the development of microarray technology and newer methods in mutation detection are leading to genetic identification, but the control of the disorder, specifically at the population level, and these methods are still at a very early age, early stage, and largely unreachable by majority of the Indian population. So it is very difficult to reach the mass, and we should work on it, how to reach the mass, and all researchers present here are can think of it. And so with we can make a thalassemia-free society with a systematic effort, which can be by educating and creating awareness with the health professionals, schools and college students, then pregnant mothers and general public, as well as developing prenatal diagnostic centers where we can have both urban and rural areas, because sometimes you see certain things are available in the urban areas and nothing when you go to the rural areas, they do not, it's not there. As well as if you go and it should be cost effective, because if it is also, even if it is there, many of the rural area people cannot avail it because of the money factor involved with it. Then because of the distance from the place needs to be taken into consideration while coming up with a strategy. Then micro mapping is also required. Then extensive screening centers need to be established, and then the concerted effort with the involvement of educational organizations, hospitals, institutions, NGOs, with medical fraternity and NGOs, and everybody together should work to reduce the disease. To reduce thalassemia, it is the requirement is like there should be a joint effort, and all the experts from various fields should come together and work for it. So the need of the hour is that emphasis must shift from treatment to prevention of birth of such children in future. Therefore, preventing thalassemia is the only practical way to achieve rapid reduction in the frequency of this particular disorder. So these are the reference which we have seen, and I would like to acknowledge here my co-author of this article, Dr. Ratika Samtani, faculty of Amity Institute of Anthropology. She has been very supportive and helpful in writing this manuscript, because at that time I unfortunately had to go through COVID-19. And my sincere thanks to all the organizers of this seminar for inviting me for the presentation, as well as accepting this manuscript for publication. Thank you so much.
Thank you so much, ma'am, for this very informative presentation on thalassemia. This presentation and the previous presentation highlights that thalassemia is one of the very significant concern for public health, and I believe that as both the presentations highlighted, that it could be controlled through universal screening and through creating awareness. So thank you so much, ma'am. Now, I would like to invite next presenter, Dr. Shivani Chandel. She will be speaking on a review of musculoskeletal disorders and psychological stress among farmers, current gaps and roadmap for future research. Dr. Shivani, virtual platform is yours.
Thank you, Dr. Sonia. So nice to see you once again. I mean, we are not able to meet.
Same here.
That is really unfortunate. And I hope we have done this seminar in offline mode, so we could all have met. And so glad to, I really would like to welcome Professor Sumati. And so nice to see you, ma'am. And I would also like to thank Dr. Kennedy for, because he's the moderator. And I can see my so senior Professor Marwa. Thank you, sir. Thank you, sir, for being here. And I would just share my screen. Just give me a minute. So I would be speaking on musculoskeletal disorders among farmers, and I am focusing on farmers. Musculoskeletal disorders, popularly known as MSDs, they are in itself very, though they are not like CVDs, they are not given that much of importance the way we give importance to all the non-communicable diseases and other comorbidities. But the problem here is that MSD, they seriously reduce the quality of life. And because of the reduction in this quality of life, we are not able to enjoy the beauty of life, the other things which we could have done it. I mean, if a person is not suffering from MSDs. So to begin with, MSDs are in itself a problem. Then again, farmers, because our country, 70% of the population engages in farming activity. So they are susceptible to MSDs. And all of us know that physical, because of the, if we go into the physical health, and we look into the details of how physical, how wrong posture and wrong this thing, excessive activity, physical activity is leading to MSDs. But there is very little focus on psychosocial stress, because farmers, they also undergo lot of stress because of many mental problems they had to suffer because of economics, family stress, financial burden, age, sex, and there are a lot of factors which are affecting them mentally, and this psychosocial stress again is causing MSDs. And there is evidence that if a person is, we ourselves, we know that when we are stressed, we experience this shoulder pain, we experience lower back pain immediately. So here I am focusing on and we are also, one of my PhD student, Miss Chonsing Shimra. So both of us, we are together working on MSDs, and we are focusing on farmers this time. Again, the work is very minimal, in India especially, and we are focusing on so a psychosocial aspect, and here I will be detailing that. And to begin with, what are exactly musculoskeletal disorders? They include a wide range of inflammatory degenerative conditions affecting muscles, tendons, ligaments, joints, peripheral nerves, and supportive blood vessels. MSDs that's why they are major burden on individual health system, social care system. There is the prevalence of MSDs, it ranges from 14 to 42%. In developing countries like India, the prevalence of MSDs in adult population ranges from 6.9 to 76.8, which is quite a lot. MSDs are results of pathological effects and various lifestyle factors such as inadequate physical activity, obesity, smoking, and malnutrition. Incidents like fracture and injuries and aging process can also lead to development of MSDs. So this is very important. The incidents like fractures and injuries. Aging process can also lead to development of MSDs. But when you age is a factor, age is a very important factor. But when we I mean, some time back when we were in pre-COVID world, so I was in airport, and I was just sitting and waiting for my flight, and I was just observing so many women and so many, especially women. I was like shocked. All of them were not able to walk. Most of them in their 40s or maybe 50s, they were not able to walk properly. I mean, some kind of ailment, some kind of visible ailment you can see. It was just an observation, like you are seeing, and you just all of a sudden realize, oh my God, why everybody is walking like that? So that was the moment I realized. I thought that I should go and read something related to this. Why, irrespective of age, irrespective of sex, irrespective of lifestyle, irrespective of diet, why more? Why people are having this MSDs? Why musculoskeletal disorders are taking place? And after that I focused, because I focused on farmers, and started going to the details of why farmers might be suffering from it. So there are certain risk factors for MSD. Right now here I am only focusing on farmers. Personal factor: age, sex, presence of other chronic disease, maybe hereditary, education, economy, sleep disorders, malnutrition, overnutrition, substance abuse, anything. And there are other physical factors: repetition of awkward working position. These are physical factors, like working position, static posture, long working hours, and rigorous work routine. Or maybe a person is spending lot of time in sitting. Then there are psychosocial factors. These are very important factors: like work related stressors, life events, day-to-day hassles. Now, when we talk about the psychosocial factors, why these are very important? Because if we are working in a community who are physically active, we would be expecting that there would be no MSDs. I mean, there would be no such musculoskeletal problems. But still there are, because that kind of musculoskeletal disorders are occupational, define their occupational health. Even if we are working on the dancing community, like for example, if we are working on dancers, we would be thinking that they dance, so they will be physically totally fit. Definitely they will be physically fit as compared to the people who are sedentary, or who are not that active. But then again comes the very important question of occupational health. And occupational health, no matter what occupation a person is in, they definitely suffer from some kind of specific occupation related stress, occupation related problems. So even in farming occupation, because of many psychosocial factors, they are very much stressed. And this stress is on the other hand, leading to these MSDs. Now the burden of MSDs: first is health burden. At the early stage, it discomfort, pain, neck, shoulders, elbow, forearm, wrist, hand. Later on, it can develop into chronic illness such as osteoarthritis, osteoporosis, sarcopenia, lupus erythematosus. Additional health burden due to the side effects, like we have many GI problems, or because of the pain, we people tend to take a lot of painkillers. And all of us know that painkillers, directly affect your liver, and they cause lot of gastrointestinal problems. And another important burden is psychosocial burden. Psychosocial burden is low productivity at workplace, home, absenteeism, early retirement from work, and reduced ability to participate in social roles, causing mental distress to individuals and the family and caretaker. Next burden is financial burden. MSDs are treated by undergoing major surgeries such as therapeutic ultrasound, joint, knee, hip replacement, O3, injecting unprocessed bone marrow aspirate to treat bone defects. At family level, including lost work output attributable to a reduced capacity for activities such as lost productivity, lost earnings, lost opportunities for family members, and lost earnings of family members. So why this is the main this is the reason why we are taking farmers, because farmers, even farmers who are seen as physically active and no problem, no MSD problem should be there, they are in particular at risk for MSDs because they are exposed to various risk factors such as adverse and working environment, several psychosocial stress like perceived debt, addiction, environmental problems, poor prices for farm production, poor irrigation, and in some region, in spite of advancement in farming tools. This is extremely important because of ergonomic intervention, there has been advancement in farming tools and technology, but because this technology is not accessible to everyone, or maybe it's not user friendly, the farmers are still using that traditional method of farming, using simple technology like knife, sickle, traditional plow, arrow, spade, etc. They are still using these traditional methods, which in turn are making them susceptible to MSDs because environmental conditions are continuously changing, and we all know that environment is no longer so friendly with us. So farming is an occupation that requires lots and lots of physical strength and energy. Therefore, farmers compromise to work with discomfort and pain in their body. They are more likely to opt for medicine and drugs that give immediate relief than to take rest or maybe take a long extra care. Take extra care to. Generally, whenever we are having this kind of thumb pain or a finger pain or any kind of wrist pain, we don't see doctor. Generally, what we do, we think, okay, we must be having some kind of calcium deficiency. All on our own, we start taking calcium or maybe vitamin D, or maybe we start exercising. We use sprays without even consulting doctors. So you can see how casual we are towards these MSDs, but at the same time, this very simple, very trivial problem, it will not allow us to lift and lift.
Dr. Shivani,
What?
5 minutes.
Okay, I will finish very soon. It will not allow us to even cut fruits. So just a simple trivial problem. So it should be looked at it very soon. MSDs are not the result of physical risk factors alone, like I already said. That's why it is important to understand the epidemiology of MSDs. Farmers, I have already I have already discussed it. Although psychosocial factors may not directly cause the MSDs, they might influence muscle tension or other physiological process. Mental distress due to low productivity at workplace and home, I have already discussed it. So this is very important. In our country, majority of population is dependent on agriculture. Therefore, the likelihood of MSDs is more. And there is no record on the prevalence of MSD in many developing countries, especially, in our country. Most of the existing studies which we were able to find, they focus more on physical stress, and only handful of studies focus on other factors like psychosocial stress. So the research on association studies of MSDs and psychosocial stress is mostly among white collar workers. That's why, and even the budget allocation is for MSDs is not available. It is not, it is minimal. This was my inclusion and exclusion criteria for the review. And this was how we selected our papers to write, finally write the review. And these are our results. What the results which we found: farmers experience most post-traumatic thoughts and anxiety after injury. They also grieve over the loss of their pre-injury life on farm. Farmers with MSDs have low quality of life, and farmers with poor quality are prone to depression. They also have high and severe levels of stress. Older individuals and less educated farmers were reported to be more prone to MSDs. The results showed that their surrounding environmental threat, loss of crops due to pesticides, make them depressed and even more prone to MSDs. So we know that because of these MSDs, I mean, a lot of this because of mental stress, psychosocial pressure, and even the longitudinal studies, they have corroborated the fact that depression was associated with significantly higher odds of reporting neck, shoulder pain, or wrist or hand pain. Therefore, in India, the financial burden were the major force of farmers' exposure to risk of MSD, such as working in high speed and less break during working hours, as farmer was paid per unit of land they harvest. So these are also some of the, this is the discussion part, as we don't have, we are running short of time, so I will not uh, dwell on it much. But the most important thing I would just like to uh, highlight here is there are several biopsychosocial models like hyperventilation theory and dysfunction of the hypothalamic pituitary adrenal axis, somatizing, which they have explained the association between MSDs and farmers. Conclusions: farmers not only ensure food and nutritional security of the nation, but also contribute a large scale to the country's economy. Hence, any danger to the well-being of farmers is a cause of national concern. It is evident that farmers are prone to both MSDs and psychosocial stress, and together it may lead to several comorbidities. There is a need to develop and promote farmer-specific psycho-ergonomic interventions, especially in rural areas, as people generally tend to neglect psychosocial stress symptoms and it remains undetected until it reaches the severe stage. The most effective method to prevent the development of chronic MSD and psychosocial stress is the management of the risk factors at early stages. It is important, these are the recommendations. It is important to document the prevalence of initial stages of MSDs. Like I said, that early management is important. Community-based awareness programs among farmers about the cost and effect of drugs and medication they consume for temporary relief is important. Strategy to provide cost-effective treatment for MSDs. Within the farming occupation, there is heterogeneity of psychosocial and cultural background. There is need to develop standardized and validated intervention tools at the community level, specifically developed for farmers. Thank you so much. Thank you all for patient listening. Stay safe, stay healthy. I would also like to acknowledge and that this work would not have been possible without my student, Miss Chonsing Shimra, because we are together working in this direction. And we thank you so much for giving us opportunity to say a few words on, just to begin with this MSD. Thank you so much.
Thank you, Dr. Shivani. It is really a very interesting presentation because somewhere we all are related with a village background, and we know that our relatives, most of them, are working in the fields, farming fields, and these farmers they make a huge portion of the economy, and often they work in very hardship conditions. So and they suffer with as you have said, with MSDs, and they ignore all these things. So I think whatever suggestions or recommendations you have made, they are very important. So thank you so much, Shivani.
Thank you. Thank you.
Now we move towards the last presentation of this session. It will be given by Professor P. Venkataramana, and he will be speaking on effect of gender, residence, and ethnicity on anthropometric parameters. So, namaskar.
Good afternoon. Hello, Sumati madam. How are you?
Sir,
I'm fine. I'm fine.
can you please, close your, speaker to a little, because it is not properly audible. Can you please speak a little closer to your
Yeah, is it audible?
mouthpiece? Yeah,
Yeah, please.
little
Good
low. That's why.
Yeah, good afternoon, madam.
Good afternoon.
Chairman, co-chairman, Sonia Kausal, my friend, and Kennedy Singh, moderator, and all the participants who are present in the webinar. Thank you so much. At the outset, I thank the organizers for giving me this wonderful opportunity to be a part of this national seminar which has been organized on the supervision of Dr. P.C.Joshi. Before beginning my lecture, I'll just give you a brief introduction about this work. So there are many research areas within physical anthropology. To name a few: human evolution, human genetics, forensic anthropology, primatology, genomics, molecular anthropology, public health epidemiology, etc., etc. However, anthropometry continues to be an important tool of physical anthropology till date. This anthropometry has been used by physical anthropologists in many kinds of researches to understand human evolution, to understand human age, etc., etc., etc. Then
Slightly increase your volume, slightly.
Otherwise, I will remove this. Abhi theek hai, madam.
Now it's clear.
Yeah, I removed the earphones. I will share my PPT now. Okay, madam. So before So what is anthropometry? Anthropometry, we all know, it is measurement of human being, whether living or dead. It is of two types, somatometry and osteometry. This calorimetry is also a part of osteometry. Then, with no need to tell about the instruments that physical anthropologists have been continuously using in recording of anthropometric measurements. However, because to understand Q, anthropometry, spreading and sliding caliper, spin-fold caliper, mandibulometer, and steel tape. Then there are different kinds of anthropometric measurements. There are linear measurements, transverse measurements, angular measurements, circumferential measurements, and skin-fold measurements. Then coming to the applications of anthropometry, this is very important. So anthropometry has been used in many areas of research. The first one is population variation. Anthropometry helps in understanding and evaluating individual variation as well as population variation. It also helps in understanding the ethnic affinities between populations. Then growth studies. Physical growth of children is studied on the basis of their body measurements. Coming to the nutrition status, so there are many methods which are helpful in understanding the nutrition status of communities. Still, anthropometry plays an important role in taking nutritional assessment surveys among populations. Then coming to design anthropometry. Data generated on the basis of anthropometric surveys of populations has been an asset of designing proper equipment for use in industry and defense purpose, spaceships, governments, etc. Then forensic science, because physical anthropologists have great knowledge in osteometry and osteology. Because of their knowledge in osteometry and osteology, they are able to, determine the sex and age and sex of an individuals. So this age and sex of an individual is helpful in the personal identification of the populations. Then coming to health research. Health. Obesity research is an important area of research by physical anthropologists. Overall obesity and abdominal obesity of the populations can be assessed with the help of anthropometric measurements. There are established studies that shows obesity is a risk factor for many non-communicable diseases. Also, in the case of COVID-19, populations with obesity has more risk than other comorbidities. This is a well-established research. And last one, in anthropometry, the technique of anthropometry has also been found extremely helpful in evaluating the physique and the constitution suitable in different sports specialties. So with this background, I'll just move on to my study. So I'll be speaking on the effect of gender, residence, and ethnicity on anthropometric parameters. So before that, there are many studies which demonstrates the association or influence of anthropometric measurements on blood pressure, blood glucose, lipid levels. But studies which demonstrate the effect of gender, residence, and ethnicity are rare. Therefore, the present study has been conducted on to understand the effect of gender, residence, and ethnicity on anthropometric variables among three populations of Andhra Pradesh, namely Reddy, Golla, and Madiga. This Reddy community belong to open category, Golla belong to backward caste, and Madigas are scheduled tribes. That is, sorry, scheduled caste population. So we have collected data from 900 subjects, 300 from each community, and 150 from urban and 150 from rural area. And we have collected samples from both male and as well as female subjects. So overall, we have recorded 20 anthropometric measurements like height, weight, some circumference measurements, some diametric measurements, and skin fold measurements. Totally, we have recorded 20 anthropometric measurements. Then, with the help of the above 20 anthropometric measurements, we have calculated 18 indices and other measures. They are body mass index, like waist hip ratio, so on and so forth, body density, percent body fat, etc., etc. So we have the list is here. We have calculated 18 indices. So now, to understand the effect of gender, ethnicity, and residence, we have used statistical analysis like means, t-test, ANOVA, and two-way multivariate analysis of variance. So before going further on this effect, I just wanted to brief the difference in gender. So in all the three endogamous populations, significantly as expected, greater values were observed in men against women. However, skin fold measurements are greater in women than men. Coming to the residence, more anthropometric variable differences in urban-rural participants among endogamous populations were not unique to endogamous populations. In all three endogamous populations, common urban-rural differences were observed. Most of the variables are greater in urban than in rural endogamous populations. However, elbow and knee diameter, forearm circumference, and some arm fat area, some measurements are more in men than in women. Then coming to ethnicity. So in studying ethnicity, we have pooled the entire urban-rural participants of each endogamous group and performed one-way analysis of variance for each gender separately to investigate significant differences in the mean values of anthropometric variables across the endogamous populations. Significant differences were observed between the populations. Then, the main aim of the study is to understand the effect of gender, ethnicity, and residence on anthropometric variables. To investigate this, the data of all participants were pooled and two-way multivariate analysis was performed. Effect of gender was observed on all anthropometric parameters except effect of gender was observed on all anthropometric parameters except of circumference and body fat, and demonstrated that gender is a significant variable that influences most of the anthropometric variables or indices. Then coming to ethnicity. Ethnicity showed significant effect on all the anthropometric parameters in the investigated population, and the variation ranged from 1.8 to 14 points. However, in the effect of residence on anthropometric variables ranged from 1.1 to 11.5. Now, coming to the last portion of my presentation, what is the effect? What is the effect of significance of effect of gender, residence, and ethnicity on the above anthropometric measurements and indices on all the 38 parameters. So till now, gender, residence, and ethnicity differences in anthropometric variables were reported using student t-test and one-way analysis variance. In this study, to know the effect of gender, residence, and ethnicity, we have used two-way multivariate analysis of variance, which not only reports significant difference of variation in anthropometric variables among endogamous populations, but also inform this is more important, percent of variation contributed by gender, residence, and ethnicity in anthropometric variables through partial ET square value. ET square value report percent of variation contributed by the compounding variables such as gender, residence, and ethnicity into the dependent variables. In this scenario, dependent variables are anthropometric parameters through which we know the gender, residence, and ethnicity impact on the dependent variables. Earlier, we have conducted some studies where we used multiple regression analysis to study the effect of gender. But here, in this case, we are for the first time using the two-way MANOVA due to the inclusion of 38 anthropometric variables and indices, which may have resulted into time consuming and also due to the limitations of using other tools for large number of variables. Now, the purpose of this study is to understand the importance of confounding variables. Here in this case, the confounding variables are gender, residence, and ethnicity. While attempting to find predictors of disease or clinical outcomes in studies in which anthropometric parameters are included, the role of gender, residence, and ethnicity are suspected as confounding variables. Till now, the role of these variables on only few anthropometric variables or indices are known. For increasing studies, are bringing the information on the role of new anthropometric variables in various disease conditions. To know the effect of gender, ethnicity, and residence on the new emerging anthropometric variables in relation to the disease conditions, research have to perform on this kind of analysis. If the information on the effect of gender, residence, and ethnicity and anthropometric variables or indices, if known on most of these variables, it will be handy information to the researchers and can be used to control their effects. In this direction, the present investigation attempts to provide information on the effect of gender, ethnicity, and residence on 38 anthropometric variables or indices. Now, Gender was shown to influence anthropometric variables and indices to the tune of 1 to 65%, residence to the tune of 1 to 11%, and ethnicity to the tune of 1.8 to 14%, suggesting that gender has a larger effect when compared to residence and ethnicity on anthropometric variables. Researchers have to take gender on account of controlling its effects while attempting to find predictors of various clinical conditions. Now, to conclude, the present study brings information on the effect of gender, ethnicity, and residence on 38 anthropometric variables indices, which may be useful while finding the predictors of clinical conditions in which anthropometric variables and indices are included as independent variables. Thank you for patient hearing.
Thank you so much, sir, Pala sir. This was the last presentation of this session. Now, may I request Professor Sumati to share the final remarks for this session.
Thank you so much for. I have been right from the day one. No, I have been listening and learning so much. I could say this is the first time I'm completely involved in more of physical anthropology combining with socio-cultural anthropology, because in general, no, we all think that we could only participate in socio-cultural session and all that. But I'm so happy that every presentator has felt the need of the socio-cultural component, right from Subbu to Venkatraman, and everyone has suggested the relevance of the cultural component and presented it and substantiate the argument that how these components, the cultural components and the social components could give them a better understanding in the whole process of understanding perceptions, and so the curative process and everything has been well narrated, and I can only say that I immensely learned from every presenter who comes from the field, and that shows their commitment, and like everybody, Shivani, when she said how an observation has given scope for her study, and Shubhu's intensive work among that, and almost, I don't want to miss anybody, Murray's presentation is so simple, and I could able to understand so beautifully. And though Rumi has felt that it is a repetition, and so I'm sure that thalassemia, because I know we have been working with some of the hill dwellers who have so much of problem with sickle cell and thalassemia problem. And when Murray was talking about the screening and her roadmap, has conclusively given a wonderful understanding as far as the issue is concerned. It's high time that we should pay attention to such things and come out with anthropological approach in dealing with these issues. Venkatraman sir, it's your presentation also, when you talked about the three component, gender, residence, and ethnicity, and it is proved that these components are very, very important in understanding health seeking system and everything, like health, wellness, and looking at the issue from a holistic perspective. So I myself don't have any questions. So all that, I'm really thankful for giving me an opportunity to listen to such a wonderful presentation right from the day morning. I don't know, somehow throughout the day I felt that I should sit and listen. After a long time, it's wonderful opportunity for me to listen to good papers. Once again, I thank the organizer for providing me this opportunity. And I will once again request Sonia to come out with her expressions in the whole presentation.
Ma'am, excuse me, ma'am.
Yeah.
Ma'am, there are some questions which will pop up in our chat box.
Yeah. I was also looking at the chat. Yeah, they are also responding. You can go ahead with it, definitely.
Shaurya, can you please read out those questions so that the speaker will interact with the audience?
Yeah, sure. There's one question from Dr. P.C.Joshi. She's asking regarding the thalassemia. A major concern is going for prenatal test and then not going forward with pregnancy. How does medical ethics deal with this? If in countries where there is a preference of male child, such screening can be used for female infanticide in such situation. What would anthropologists recommend? So I request Professor Romi Dev and Professor Muri
can respond.
Can respond.
Who should respond? More? Professor More, should I?
Please, yes, please, ma'am. Please, ma'am. Yes.
I can just, in this context, like, what I feel, because prenatal sex selection was seen as a solution to a number of problems when it came up initially. But then it was actually, in a country like ours, it was misused. So according to me, and as the question goes like this, like how anthropologists can be helpful in, so the only thing I feel like we as anthropologists, we can sensitize the population, we can sensitize the human genetics community and make them aware of the magnitude and of the misuse of the prenatal technologies and its impact on the sex selection, which is later on is impacting the sex ratio in the country. So this is what I feel from my point of view. If Professor More wants to add something, can say. But I feel like creating awareness among the population as well as the medical genetics community who would be working on this the misuse of such technologies. So More, if you have something.
Yeah, I think that should be sufficient. Professor Rumidev has clearly said. I just want to add one thing.
The question goes like this from the anthropological perspective, yeah.
Yeah, if I may add one thing here. In fact, prenatal screening is not only a problem in India, even in advanced nations, it is quite a problem because that is not the right time to tell the couples that their child is at risk. So that is why a lot of emphasis is given on premarital screening. As far as thalassemia is concerned, even in the West, and both in India and in the West, the emphasis is given on the premarital screening, where you catch them young, the college going and the high school going students, and give them training. So, and they can be screened for thalassemia, so that in future, they may not have to go for prenatal screening as far as it concerns the disease thalassemia. So this emphasis is very well worked out in both the West and even in India. The only thing is that, as Rumi ma'am has said, we have to really sensitize the population. Yes, thank you.
Thank you, sir. Thank you, ma'am. There is another question by Dr. P.C.Joshi again. She wanted to know about the link. So would you also link farmer suicide to MCD related depression? I think Shivani has already answered this question. Shivani, would you like to add something more to this? I think Shivani is not here. Hello, Shivani. I guess Shivani has already answered
Yeah, she
Yes,
has already answered in the
She has
text. I
responded.
think.
yeah, you're correct.
Fine. Okay. All I could say is that because when this session started, the first presentation by Professor Subharao, he very aptly raised this question whether we can combine sociocultural anthropology and biocultural anthropology. So I think all these presentations have answered this question very well. So I thank all the presenters for this wonderful presentation. So that's it. Thank you.
Thank you so much. Vitoli, you would like to conclude or
Okay, ma'am. Ma'am,
would you
this is
like to conclude or would you like to convey a
yeah.
few announcements?
Kennedy will conclude.
Okay.
Okay.
Ma'am, I'm here.
Yes.
Mr. Moderator, so I just want to say a few words. So
Yeah.
on behalf of the department and on behalf of me, I just want to thank all the chair and co-chair. I really thankful to you on my behalf and on my department. And I also really thankful to all the presenter, Professor Subare, Professor Muresar, Professor Romi Dev ma'am, Namaste ma'am, Sivani, Dr. Sivani, Dr. P. Venkataraman, and all the what to say all the audience who are offline, online, and I think in many of the what to say audience, I can figure out some of the name like our teacher, Professor I.S. Marwa, Professor Aruf Ratan Bandyopadhyay, uh, and Madam Biba Joshi, Madam Mitra, Mita Srimitra, and many of the people they are watching on us. They are constantly listening from the very beginning, and we have a very constant interaction on this particular session. It is a very interesting session, and I would again appreciate all the presenters for being with us and for the contribution that you bring us today. And it is a very thought-provoking interactions, and we learn a lot. And I think it make a little payment to all the future resources in the department. So I'm very much thankful to all of you. Thank you once again. And
Thank you. Thank you so much.
okay,
I'll have the pleasure to.
Thank you.
So
over
we'll
to
see
Prof.
you tomorrow.
Yeah.
Thank you,
Over to
Kennedy.
Prof.
Okay,
Thank you.
thank you, Dr. Kennedy.
Thank you very much.
Okay, and thank you for winding up the session at the right time. So we all are running almost on time, and we hope to see you tomorrow morning at 9 a.m. for the day 2. Okay, thank you
Right.
everyone for your support and presence.
Okay.
Thank you.